Please, everyone be seated. We'll be beginning our sessions shortly. Thank you.
Good morning, everyone. In the interest of time, we'll get started. We are just a couple of minutes late, and usually our sessions, they're so intense, we run short of time, so we'll just get started. Well, again, good morning, distinguished guests, colleagues, and friends. My name is Somesh Kumar. I serve as the Senior Director at Japaigo, an affiliate of Johns Hopkins University. It's my privilege to welcome you all to this important plenary on setting the regional agenda for emerging infectious diseases in Southeast Asia. I'll not give a lot of gyan on this because we have had a lot of deep conversations over the last couple of days. So I'll just refer to, as we get started, to a session, a whole day symposium that we had yesterday on the exact same topic in partnership with our partners, Asian Development Bank, India Health Fund, Hakdarshak, Satwa, with participation from multiple agencies and organizations all across the world working in Asia and Southeast Asia. I'll just share some insights, what I took home from that whole day symposium to get us started. First, we heard that from multiple countries. We had country representation from India, we had representation from Bhutan, Nepal, and Philippines, government representation. So we heard from these countries that the real work of preparedness happens quietly through community health workers, local teams, and everyday vigilance. One of our panelists, Professor Anurag, reminded us, quoting the Black Swan, "You lose money every day to prepare for the big thing," as in you're preparing for you're investing in something that you hope doesn't ever happen. Second insight that I took home was we can not work in silos anymore. The threats we face, AMR, climate change, fragile health systems, don't exist in isolation. Neither can our solutions. Our earlier sessions made it clear the future belongs to those who build bridges, not walls. Third, none of us can do this alone. Not governments, not funders, not scientists, not community leaders. We need to stand together. This must not be the end of the conversation, it must be the beginning of a new kind of teamwork. As the movie Interstellar reminded us, we must think not as individuals, but as a species. The future we are trying to protect demands nothing less. I am hoping that this session is a great start in fostering some of this teamwork, this collaboration across countries, across agencies, and across stakeholders. With this, let's get started. I would like to invite our esteemed speaker, Dr. Nilesh Buddha, for the scientific spotlight on strengthening regional strategies for emerging infectious disease preparedness. Dr. Buddha is the lead for regional emergencies at WHO's Southeast Asia Regional Office, CRO in New Delhi. He is currently serving also as the acting regional emergencies director at CRO. He's a public health physician from India with experience of more than 25 years across India, Africa, Caribbean, Europe, and Southeast Asia. Dr. Buddha, the stage is yours.
Good morning, thank you. Greetings from WHO Southeast Asia Regional Office. I've been working in these regional health emergencies, including emerging infectious diseases, for the last many years, and it's a great opportunity to share some of the lessons learned in the Southeast Asia region based on recent COVID pandemic and many other outbreaks. So of course I talk about Southeast Asia region of WHO, and this is almost 2 billion people from India to Indonesia, and then North Korea incidentally is also part of the WHO Southeast Asia region. Many densely populated cities, urban areas, a lot of vulnerable population, different kinds of vulnerabilities, emerging diseases, and also natural disasters. We also have a couple of big conflict situations, humanitarian situations in Bangladesh, in Myanmar, and all these do not help in better management of outbreaks and pandemic. So of course the morbidity and mortality, the number of people who die, number of people who become sick, that is the most important part of it. But there are various other things, including burden on the health system. When we deal with the pandemics and outbreaks, the essential health services for many other diseases get disrupted. The travel associated cases and the whole management of it leads to a lot of disruptions of economy, of societal life. And then, of course, there is fear, stigma, and discrimination we recently experienced in the monkeypox public health emergency of international concern, that the Southeast Asia region was at the receiving end. The interspecies transmission, as just now was mentioned, quoting Interstellar, if we talk as species, then this interspecies transmission is also a very important thing that influences the understanding and the management of pandemic. So this is quite a well-known slide actually. For last couple of years, the different sectors' impact on COVID-19 pandemic. You see how COVID-19 pandemic's economic impact resulted into multiple times. I think it's more than 40,000% compared to the previous outbreaks, or at least the global economic impact of HIV, TB, and malaria together. More than 1.6 billion children were out of school. All these lead to a long-term impact. More than 7 million actually officially reported deaths, but then there are multiple mortality studies which project many more deaths. So these are the serious impact of COVID-19 pandemic that we must not forget. I have been working throughout in Southeast Asia during the COVID-19 pandemic, and we did some lessons learned workshops. I remember Dr. Srinath Reddy was one of the guest experts for the lessons learned workshop of the Southeast Asia region before a couple of years, that what did we learn and how we can further improve. So high-level multi-sectoral leadership is a must in the country for pandemic-like issues. That's what all the Prime Minister office and President's office were heavily involved. But we need to sustain these in an institutionalized manner, and I have a slide about it, that what mechanisms we are proposing. The vital role of primary health care systems, because all the countries who dealt little bit better with pandemic, they had a good public health and primary health care systems. It cannot operate in vacuum just for pandemic preparedness. The risk-based approach and the relevant legislations. We have IHR and we may have also pandemic treaty in a month or two, but the relevant legislations in the countries are most important. We also saw the importance of digital technology for surveillance. Multiple lessons in different sectors, starting from surveillance to how the genomics and the laboratory strengthening helped countries accelerated their infrastructure for laboratories. At the regional level, the regional platform for alert preparedness and response, that's what is required, is there, but it needs to be further strengthened. And then timely sharing of surveillance-related information, pathogen, and its information, so that everybody knows about it, and then there are such legal provisions in the international instruments, but the countries need to follow that. So WHO as an institution, based on the lessons, experience of COVID-19 pandemic, and through various high-level intergovernmental panels, they came up with the 10 proposals to strengthen pandemic preparedness and response throughout the world. And we are also implementing it in Southeast Asia. Most of these proposals are publicly available on the WHO website and others. A couple of them which are very important, I will go through it. But it covers governance, financing, and the technical systems, part of the whole business of pandemic preparedness and response. And as I was mentioning, there is nothing like pandemic preparedness without primary health care, health promotion, and health security. Everything works in one health system, and the health system also doesn't operate in vacuum. It has to work in synergy with multiple sectors and multiple systems within the country, within inter-country mechanisms, regional and global mechanisms. Then only we mean business. So these are, in spite of lot of geopolitical and economic issues globally in last few years, these are shining examples that the health diplomacy still works. And we have now revised, amended international health regulations based on the experience of COVID, when countries did not report data pathogens on time, when countries implemented lockdown without proper epidemiological analysis, when countries went for a travel ban when a new country reported a new variant. All these are addressed in the new or amended IHR, International Health Regulations. The entire world actually is a signatory to it. Within 1 year, these will start getting implemented. Hopefully, it should work. Of course, it's supposed to be a legally binding instrument for all the member states of the WHO, which are more than 190. And then there is pandemic agreement, which was just agreed upon before a couple of weeks, after 3-4 years of tough negotiations. Some of the big issues like pathogen access and benefit sharing India, or for that matter Indonesia, I would like to give an example of Indonesia here, where Indonesia shared their pathogens about flu virus, and ultimately those pathogens and the information go to the pharmaceutical companies, mostly in the West. They developed the vaccines out of it, and then Indonesia itself did not get the vaccines. And that's how, this is before 20 years actually, and that's how this thing actually got seriously known during COVID-19 pandemic, when many countries hoarded vaccines up to 8 times of their requirement, when health workers in Africa did not get a single dose. And so all these issues were discussed in detail in last couple of years by the member states, by the countries, by their diplomats. And then finally on 16th April they agreed on a draft that will be considered after a month in the World Health Assembly, hopefully for an adoption. Of course there are still details to be worked out, but this is a very good example that in spite of all these challenges, countries, people, governments want to work together for a better, safer world. So that is the governance part of it, the IHR and the pandemic treaty. Then there is financing. A lot of new innovative financing mechanism for pandemic preparedness and response are being proposed. One of the shining example, and I am sure Priya will talk about it, is a pandemic fund. The Southeast Asia region of WHO received more than $100 million in last year or year and a half in the first 2 rounds of pandemic fund. And we are also very hopeful and working hard for the round 3. It's a very institutionalized, very well established governing mechanism around it, and it can make and is already making a lot of good difference, significant impact in countries. And then there are systems which are quite technical discussions, but pandemic we are talking about, actually the heart of it is public health technical aspects, the surveillance, the community engagement, the scaling up of oxygen facilities. When Delhi, this place, suffered lack of oxygen in the hospitals, lack of beds for seriously ill patients. We have seen it. I myself struggled to get a bed for my own office staff. So we have seen it, and so the scalable care is one of the important component of the new HEPR framework. HEPR is Health Emergency Preparedness and Response. The whole world, all the agencies, all the governments working for it, they are more or less following it. Based on this, the Southeast Asia region of WHO in last 3 years, based on COVID lessons, have come up with a few health security frameworks. These are being implemented in the countries by the governments, by the WHO country offices, in coordination with the local partners, stakeholders present in the countries. And these are actually solid foundations of strengthening health security, tackling emerging infectious diseases through systemic approach in the countries. There are a lot of challenges, there are huge financial issues, coordination issues, governance issues, but we are addressing that. There is a whole system of flu pandemic preparedness. The most important pandemic that was and will be is going to be flu. There is a whole system around it for last 50 years. And WHO Southeast Asia region and its countries are a very active part of it. All of them are members of the PIP, the Pandemic Influenza Preparedness Mechanisms. There is a partnership contribution mechanism around it, where countries and pharmaceutical companies come together. They contribute to the vaccines, the drugs, the medicines, the diagnostics, but also countries get real cash money to strengthen surveillance out of it. It is a very good mechanism that is working, and all the countries of the region are an active member of it. 1 minute left. Okay. I will skip then Nipah. Nipah is an important emerging infectious disease of our region. India, Bangladesh regularly report it. We have a regional strategy on Nipah prevention and control. We have started implementing it, covering all aspects of it. This is advancing laboratory systems, very important. We saw different variants and its characteristics and how do we know about it and how do we control. This is the slide for the future, and I want to spend 30 seconds on it. This is the mechanism that we have proposed. The Southeast Asia region of WHO has proposed that the heads of governments should come together in an institutionalized mechanism. We call it Regional Health Emergency Council, where they can meet in person or virtually once a year or once in 2 years and take some important decisions, so that multiple sectors within the country and inter-country cooperation mechanism can continue to work in the interest of a safer region for emerging infectious diseases, for pandemics. We have a detailed brief or concept around it, and the governing mechanism of WHO's CRO, the Southeast Asia region, where all the health ministers sit, they have in principle agreed and they have asked us to further work on it, because there are similar mechanisms being proposed globally under IHR and under pandemic agreement. So we don't want to duplicate, we want to synergize with it. So as of now, it is in the holding bay, but we will revive it as the global scene develops. So we are very acutely aware of these global developments and trying to make the best of it in the interest of the region. I think that's it. Thank you very much.
Can you all see me? Okay, great. That's a problem when you're short. Thank you, Dr. Nilesh. This was very helpful and very enlightening. I'm sure we're going to discuss in detail with the panelists, but also the audience later. This is the last day of the World Health Summit, and all of you have showed up on a Sunday, which is commendable. So thank you for doing that. So far, whatever sessions I've attended, especially if I've moderated, I've never stopped the speaker from talking. So instead of 2 rounds, we've had 1 round, but we've let them talk. But we'll do this a little differently today because it is the last day and all of you have showed up. I feel it's important that we make it even more interactive, and panelists have already spoken a lot. I know they're tired by now. So we'll tell them to be brief, but we will let you ask questions, or we will ask you questions and try to answer it together, right? So this is what we're going to do today. I would also like the audience to think that after these 3 days, what has been 2 key takeaways for you? Maybe we'll ask you as well and get inspired, right? So think about it, and we'll ask you to raise hands at some point and give us and let us know what you've learned so that we can see if we are in the right direction as well. Okay, so this was about how we're going to make this interactive and fun. I'm going to start with the introductions. Some of the people I've been introducing for a while now, so in the last 2 days. So we're going to do it slightly, perhaps differently. I'm going to start and call my panel, and I'm going to start with somebody who I've said this before, but I don't think I could find better words. He really doesn't need any introduction. A lot of us in India studying public policy have either read of him, have been trained under him, have been inspired by him. So, I mean, the man who really needs no introduction, honorary distinguished professor at Public Health Foundation of India, who previously served as a president, Dr. Srinath Reddy. If I may invite you on the panel, please. He's a respected voice globally. He also continues to teach, and I had the privilege of teaching one of his classes, and it was a lot of fun, and all the students were in complete awe of him, as they should be. So, even a lot of us here have been talking about how they've been trained under you. In the morning, I was in the green room, and someone said Dr. Reddy, and someone, it's like, which Dr. Reddy? It's like, there's only one Dr. Reddy that we know of. So I think that was you. Yes.
I thought you were short of time.
Yes, but also trying to make it fun. Also can never talk enough about you. Sorry, it's a personal problem. Next, I'm going to call in Ms. Priya Basu, who's the executive head of the Pandemic Fund at the World Bank. I mean, to be honest, Pandemic Fund has contributions from all the key agencies, including ADB, WHO, and other multilateral agencies. This fund was set up during the pandemic. She is really the person you should network and get in touch with if you want to get grants on pandemic preparedness. They've been giving grants from across the country, including India. We have one of our projects on animal health with Pandemic Fund. So that's Priya Basu, not getting into the detail of it, but looking forward to have her in the panel. Then we have this, she's from Romania. She's a physician and a public health practitioner. If you don't know her by now in the past 2 days, then you haven't been at World Health Summit. If there's anything about TB that you want to know or learn, then it has to come from Luchika. And I'm going to wait, not give in too much to you, but the passion that she has for this subject is absolutely contagious. So Luchika, please come on the stage. We welcome you here. Okay, the next person I'm calling is also a dear friend, and I've goofed up her introduction before, so I hope I don't do it now. Ms. Jaya Singh Verma, who's here. Sorry, getting it right. Policy advisor at FCDO and a senior officer for managing climate risks in urban poor and rural poor, and also brings in a very strong gender lens to climate. Welcome, Jaya. Next is Mr. Brian Riley. He's a health specialist at Asian Development Bank. He has over 25 years of experience in the health system. He was previously with the WHO and now with the Asian Development Bank. He's really our champion for climate and health. For the past few years, I've been working with him. And anything related to climate and health, he's the man. Fun fact about him, he owns about 100 guitars, and I've seen that in Philippines. So he's flown from Philippines, he's an Aussie himself, but man, his guitar collection. So any of the musicians here, get hold of him. And beer. Don't forget the beer if you want music from him. Our last but not the least panelist, I'd like to invite Dr. Monica Kocher. And give me a moment, sorry. She's a distinguished public health professional with nearly 3 decades of experience in climate, public health administration, and strategic policy. She currently serves as an advisor at Dakshin, Global South Center of Excellence, an initiative by Ministry of External Affairs. I know her from PMJ days. PMJ is the health financing scheme, and she was working at the state, and we've worked together at that point. So happy to have you. Okay, should we start with the questions from the panelists or leave them behind and just ask you? I mean, we've got them on stage already, so please do get ready. We're going to come to the audience as well in between. Should I do a rapid fire first? Kidding. I'm going to start with Dr. Reddy. Dr. Reddy, a lot of us here are from public policy, but we want to understand from you, what are the key challenges that we can think of, not just for India, but for the region, specifically with focus on emerging, or as we say, re-emerging infectious diseases? A lot of us have also started calling infectious disease as persistent pandemic, not something we can just forget with NCDs, etc., especially with climate change. So what are the key challenges and how can public health systems address those? Over to you.
I think Dr. Buddha really summarized it very well in his opening presentation, so I would not like to repeat too much of that. But given the fact that we do have a host of diseases which are really emerging with a considerable amount of alarming speed with climate change, we know that vector-borne diseases, waterborne diseases, and even infectious disease outbreaks with a pandemic potential because of zoonotic spread, all of these are going to be important challenges as we move along. Then, of course, we do have a host of persistent health challenges, tuberculosis particularly drug-resistant tuberculosis. Even HIV is not fully gone out yet. It's under some control, better control than before, but nevertheless, it's a challenge. And there are unspoken challenges which are not very much discussed in the public domain, like reproductive tract and urinary tract infections among women, with about various surveys showing 10 to 25% of women have that, and that's likely to be underreported. Therefore, there are a number of challenges that we need to consider in terms of the infections, and certainly infectious diseases are never going to go off the map of public health. But I think the important thing is to try and find out how our health systems are geared up for it in different countries with different resource scenarios. So given the fact that both financial and human resources are relatively constrained in most countries, we find that effective surveillance systems do not exist, especially in primary health care. And as has been rightly emphasized in the morning, primary health care is the foundational basis of a good health system. And we cannot really have poor surveillance systems and poor reporting systems over there and expect us to control the diseases. Obviously, with the pandemic treaty coming in, with the IHR having been revised, most countries are now beginning to reposition themselves. Nevertheless, there are both financial resources as well as technical resources, particularly in terms of numbers of trained personnel and their deployment in various settings, particularly primary care. And while much of the world is now progressing rapidly with new ways of detecting diseases, from molecular genetics of microbes to wastewater surveillance, we are really lagging behind in many of these areas because our health systems are not really geared up to introduce many of these elements, not all of which require sophisticated equipment, but certainly require system revamp. But as has already been mentioned, there are many other elements missing here as well in terms of community engagement, in terms of adequate data generation and transfer. We need data to be transferred across national boundaries faster than microbes and their variants can travel. So clearly, we do require much better revamping of many of our systems. And it's already been mentioned that our domestic capacity for production of vaccines and drugs also to be needs to be geared up in a situation where it's not only trade, which becomes a formidable barrier, but also supply chains break down during a public health emergency. So having that level of local self-sufficiency is important. I'd just like to conclude by saying that this cannot be done in a reactive fashion. It has to be a proactive preparation. Unless you have an effective, equitable, empathetic, and economically efficient health system functioning reliably in the steady state, even without an emergency, you will not be able to generate a strong, swift, and sustained surge response. And when I say surge response, even in human resources and in supplies, you need to build that slack, that additional capacity which can be called upon in a public health emergency. You can't scramble around then. So these are the things that we must attend to as we move along.
Thank you, Dr. Reddy. It's never going to be easy for us to be able to solve all of this, right? It's extremely complex, but I'm going to ask you a quick, rapid follow-up question. If there was one low-hanging fruit that we could advise the policy makers on climate and health or pandemic preparedness, one low-hanging fruit, what should they focus on?
Strengthen community-connected surveillance systems in primary care.
Okay.
I would say that.
Great. Thank you. Very useful. Over to my co-moderator, Dr. Sumesh.
Thank you, Asta. I loved the empathetic part of the health systems you talked about. Really, I think we have not talked about it a lot, and it's such a powerful reminder of how we have to think about whom we are serving and what they need and where they need and when they need it, rather than thinking from our side how we deliver. Thank you for bringing that point. I'll use it more now and in a very strong, articulated way. So I'll move to Ms. Basu from Pandemic Fund. You know, since yesterday and when I was also opening it, we talked a lot about cross-country responses, right? And how that has become a very centerpiece of planning for the next outbreak, the next pandemic, and all the efforts that goes to it. So whether it's data sharing, whether it's cross-country laboratory systems, cross-country manufacturing capabilities, or cross-country surveillance or cross-country response systems, all of these are so critical in thinking together and thinking in a very coordinated manner. How is Pandemic Fund investing in such cross-country or supporting such cross-country collaborations as you obviously invest in building core capabilities of countries? Priya.
Thank you so much, and thank you for inviting me to this panel. It's really a pleasure being here this morning. First of all, let me say I couldn't agree more with what Dr. Reddy and Dr. Buddha said earlier. Just to emphasize that the aspects we're talking about this morning about stronger surveillance systems, better laboratories and diagnostic capacities, community, strong community health workforce. At the primary healthcare level, these aspects really are integral to health system strengthening. And I'm afraid they're often neglected elements of health system strengthening, as we learned from the COVID pandemic, right? But it wasn't just the COVID pandemic. Before that, SARS, MERS, avian influenza, Ebola, Zika. Each time there was a pandemic, we realized that the world hadn't invested enough in these core capacities at the primary healthcare level, which is why, we allowed a tiny virus like COVID to disrupt the world the way, we were disrupted, the millions of lives lost, not to mention the trillions of dollars of economic losses and reversals in hard-won health, economic and social gains, and reversals in SDGs. So, I'm really happy that these elements are being highlighted at the World Health Summit, because I'm often in conversations around health system strengthening, access to affordable quality healthcare and so on, where the focus isn't necessarily on these very important elements that we're talking about today and that we've talked about in the course of the last 2 days. Now, turning to your question about the Pandemic Fund. So the Pandemic Fund, as Dr. Buddha mentioned, really is one shining example of a concrete financial mechanism that's come out of the ashes of COVID-19. There were a lot of ideas and proposals out there, lots of lessons that people were talking about, but really speaking emphasis around the funding gaps and so on. The pandemic fund is it's now up and running. It's been 2.5 years now in operation. It came out of lessons learned from COVID. It really is an example of how multilateralism can work. 25 countries and 3 philanthropies came together at rapid speed to provide seed capital of $2 billion, and now we've raised an additional $1 billion, so we have now up to $3 billion. We're actually fundraising for more because the demand is enormous. Each time we announce a round of funding, we get 8 times as much in terms of funding requests. In total, we've received over $7 billion in terms of requests from low and middle income countries. We are focused on low and middle income countries. Our emphasis is on strengthening surveillance, strengthening labs, strengthening health workforce, with a strong kind of cross-cutting focus on One Health and community engagement. We've done some interesting projects already, awarded grants for interesting projects in this region. We have single country projects that are already operational, and recently we launched a multi-country project with 8 countries from South and Southeast Asia: Bangladesh, Bhutan, India, Sri Lanka, Maldives, Myanmar, Nepal, and Timor-Leste. Our model is always that we channel money through a group of accredited implementing entities that international organizations that provide sort of the knowledge and technical support, and also oversee the use of resources. So in this case, in this Southeast Asia project, the 4 implementing entities are the World Bank, the WHO, FAO, and UNICEF. And it's a big project. It's almost $1 billion because of the large amounts of co-financing that the international agencies have brought to the project, and also the investments that the governments themselves from these 8 countries are putting in. They're putting in about $367 million of their own money, which kind of ensures the sustainability of the investments that we're making. And the kind of areas, this kind of cross-country effort is really critical, because at the end of the day, if you're able, in order to be able to quickly detect and contain an outbreak, you've got to have data sharing. You've got to have, good intelligence gathering that's available across countries. So what this project is doing is it's focusing on collaborative surveillance. It's fortifying the public health data and intelligence systems in these 8 countries. There's investments in environment and wastewater surveillance with real-time water quality monitoring, analysis, reporting, and data sharing. There's an effort to do regional diagnostics and build a kind of a regional lab infrastructure and sort of quality management of labs, and then establish a regional multidisciplinary reference diagnostic network. So those are kind of the areas. And then at the center of all this is also training, developing regional health workforce, field epidemiology training programs, and building a skilled WASH workforce. So, at the end of the day, and I'll stop here, but, the goal here is that there'll be strengthened collaborative surveillance across these 8 countries for timely detection of health threats. There'll be good environmental and wastewater surveillance to detect diseases, with epidemic and pandemic potential. There'll be improved labs and diagnostics infrastructure to characterize and confirm pathogens, and there will be a workforce that is, that can be used in peacetime, but can be surged in times of crisis. Thank you.
Thank you, Priya, for laying out all the different elements of the work that you're supporting. I have so many questions that we'll probably do it post-meeting tactically, because these are very hairy problems, doing cross-country collaborations. How do you bring governments together in what kind of governance mechanisms? But I'll, in the interest of time, move on to you, Brian. And following on Priya's lead here, and she talked about how the pandemic fund is investing in the cross-country capabilities and also responses in different ways. So if you can talk about ADB's investments and support in this space, of how your countries, how you are supporting rather countries in developing their preparedness, specifically as it relates to climate vulnerabilities, primary health capabilities, surveillance capabilities, and maybe I'll add just a layer to it. I'm just merging my two questions, a bit of cheating there. From what you have seen, different funding mechanisms being executed, designed and executed, whether it's blended financing, result-based financing, what have you seen? What are your learnings, early learnings there from what are the kind of things that seem to be working?
Oh, great. That's a great question. And firstly, yeah, Preya's summary of the breadth and depth of the financing across the entire health system is really important. ADB is similarly working as one of the implementing entities for the pandemic fund and supporting our countries to develop proposals. So, and we also work very closely with my colleague Jaya here, the FCDO, on what we've launched a number of platforms, a climate and health initiative, which the bank launched at the COP28 in Dubai, 2023, and I'll talk a little bit about that going forward. That aims to sort of build capacity, generate knowledge, develop standardised country-level diagnostics and assessments for climate-vulnerable infectious diseases. And we've got a few platforms that we're going to be launching at a major regional event, I might add, in July in Manila. We're calling the Inspire. And one of these major investments that we're looking at for our health investments is what we call the Excited, Ending Climate-Vulnerable and Tropical Infectious Diseases and Emerging Diseases. So I'll talk a little bit about that. In terms of the financing spread, so the bank, the ADB, has committed sort of to be the 21st century climate bank and allocated $120 billion in a range of different financing modalities through to 2030. Some of those, I might just enumerate what these modalities are, because what we often talk about in different fora is funding, but from the bank's perspective, it's really financing. And the reality is the fiscal space for TA money and grant money, untied money, is becoming constrained. And it's our financing modalities through concessional loans, which we are also sort of promoting as one mechanism, and leveraging the private sector's investments too. So some of those are the Asian Development Fund, which provides concessional loans at competitive rates, supported by some grant and technical assistance money. So we also use our ordinary capital resources, offering loans on very competitive terms for particularly low-income countries. We have ADB managed trust funds, a number of which we're managing in the climate and health space with FCDO through the Urban Resilience Trust, which is really providing some valuable support for community-level climate resilience. And I'll talk a little bit about that. Let's talk about some of the loan modalities. So, we have policy-based loans, which are really dispersed to ministries of finance for really introducing systemic-level policies aimed at building climate resilience and addressing climate threats. We have results-based lending modalities, which is really dispersed to governments, sovereign entities, on the achievement of results, be it policy reforms, being it investments in health infrastructure, building health workforce capability, introducing early warning surveillance systems, etc. So we can lend at very competitive terms for those sorts of measures. We have direct investment loans, particularly to non-sovereign entities, private sector companies who have a significant social dividend or yield results. And then, of course, we have our technical assistance, which really focuses on capacity building, strengthening community-level resilience to climate threats, building capability to respond, strengthening, the prepositioning of medical countermeasures, etc. Look, I might leave it there, and if we come back for some second questions, we can dive deeper into some of those measures. Thanks.
Thank you, Brian. I noted the TA money is going down, but it's still there. So I noted that with interest. I hand it over to my co-moderator, Astha.
Thank you, Dr. Somesh. Actually, you've been very kind. You didn't follow up with any controversial question or quick rapid fire, so I'll just ask to the ones who Dr. Somesh did not ask. So, Priya, I'd start with you. What is that one thing that you think countries should do when they're looking at pandemic preparedness? Please note that the grant will be reviewed by them, and I think they'll just give us the answer, what you should do in your application. Let's hear from you.
Well, I was going to say the one thing that countries should do when they think about pandemic preparedness is invest in epidemic-ready surveillance systems at the primary healthcare level. But you're asking me about what they should do in preparing their proposals. So I think, you know, what we've learned, and we've kind of baked this into the DNA of the Pandemic Fund and the way we ask for proposals, because what you get is what you ask for, right? If you don't ask for the right thing, you're not going to get the right thing. So, you know, a few things. One is really the importance of sort of collaboration. The global health system, global health architecture is very fragmented. There are so many different financiers, all of whom are sort of trying to do similar things, often stepping over each other's toes, knocking on the doors of the government, offering kind of similar things. We're saying, and so then you end up with the whole being smaller than the sum of its parts. So what we're saying to countries is when you're putting together a proposal, and all our proposals have to be country-led, country-driven. So we're saying when a country or a group of countries or a regional body puts together its proposals, please work with these, you know, we have these 13 implementing partners who are the main kind of actors in the global health space. Please work with them, get them to collaborate, bringing their own knowledge and expertise together so that a country gets a coherent stream of financing. Sure. So I think that's one thing. And the second is, please also invest your own resources on your policy commitments, because without that, whatever we do is not going to be sustained.
Sure. Thank you. Brian. I know you've been working on climate and health for the past few years, and I've been working with you myself. So one key priority that you'd really like to see implemented from the climate and health initiative ambit that we've been working on?
No, thanks, Asta. I'll keep this quick. One thing we've noticed over the past years is rarely do ministries of health and ministries of environment come together at, you know, on a similar platform to discuss where the best co-benefit might be through climate financing modalities to deliver health co-benefit. You know, one of the bank's observations is that because we can deal directly with ministries of finance and treasuries, is that sort of capacity to bring different ministries together, sort of generate some multi-sectoral responses, to really also talk about health co-benefits from other sectoral investments with treasuries, with finance ministries, is a real dividend for health. And then, of course, building health sector capacity to understand the environmental driven funding modalities, the NDCs, having national health adaptation planning in place. There is quite a serious lack of capacity in the health sector to understand that stream of financing. So to bring those ministries together is really important. Thanks.
Thanks, Brian. Okay, before I go to Jaya, who's my next panelist, Jaya, give us 5 minutes, because I promised the audience that we're not going to leave them behind this time. So we're going to change the format. With these 3 panelists that have spoken, if you have any question, we'll just take one question, and then we'll move to the next 3 panelists. Or you could give me your key takeaway from the last 2 days or this session. So just one question. Sure.
Thank you very much. Esperanza Martinez from the Australian National University. Brian, you mentioned this element of having to bring together ministries of finance, climate, and health. And you say that's imperative. The question very often is the incentive to do that. Each one of them, I mean, everyone operates in silos, and the ministries are not different. A very big incentive is to have funders actually creating those platforms. So my question is, you say this is urgent and a priority. Is ADB and other mechanisms like the Pandemic Fund doing that and saying, we would like to discuss financing with you for climate, but we would like you please to bring along your Ministry of Health and your Ministry of Climate or Environment to this conversation? Are you using that leverage that you have from the financing perspective to be that driver force that bring them together?
mean, I won't speak for Priya, of course, but I'm sure we have some similar views. Exactly, that's exactly what we're doing. In fact, in India, in September last year, we convened the inaugural, what we call the Climate and Health Conclave, which in fact brought the Secretary of Health, the Secretary of Animal Husbandry, and the Secretary of Environment together, along with state and provincial leaders across those 3 ministries, to deep dive on 8 very clear things: early warning, surveillance, pandemic response, managing heat, and developing a strategy for heat, but with the 3 ministries, dealing with climate. And we provided the platform for that. We provided and we'll gear TA to support those things and grants, and of course we'll encourage loans to be geared to include those 3 ministries.
Yeah.
And we plan to have, that was the inaugural one in India, which was so successful that ADB is planning to convene another 3 in 2025, Indonesia, in the Pacific, PNG or Fiji, and in the Philippines. So they, at national level, bringing those 3 agencies together with the bank's sort of convening power has been very, very powerful. With our partners, of course, WHO and the international agencies. Yeah, really important.
Actually, one of the strengths of the Pandemic Fund is the fact that they've been able to get us together. So ADB, World Bank, FAO, working with Department of Animal Husbandry, and not just health, on a health issue was something that's never happened before. And you see, that's the power of an international agency like Pandemic Fund.
Yeah, so I mean, I can just add that really that is something that is a central focus of all that the Pandemic Fund is doing. We're really asking these proposals not just to collaborate across partners, but across ministries. And we're seeing, you know, in project after project, we're seeing how, or proposal after proposal, we're seeing how ministries of health, finance, agriculture, environment, animal husbandry are coming together around One Health. One Health often is a theoretical concept because of this collaboration and because the ADB is bringing its expertise, the FAO, the WHO, the other multilateral banks bringing their expertise together, and then different arms of government bringing their expertise together. We're seeing One Health in action. And what does that mean? When we talk about laboratories, it's animal labs and human labs. When you talk of workforce, it's veterinarians, it's animal health workers, doctors, nurses, community health workers. When it's surveillance, it's livestock surveillance and human surveillance. So, we're really seeing this. 85% of our projects are taking a One Health approach. So.
Great. I don't want to keep Jaya waiting. She's really our donor also. Sorry, Jaya. Okay. Jaya has been working in climate and health and across, actually globally. We've been working with Jaya as well, and like Brian mentioned, on climate and urban space. Jaya, from you, we really want to understand a global perspective of some of the innovations that you can bring in that can perhaps be replicated by some of us here, or at least be funded by you.
So I can talk to the first one, Asta, which is about the innovations. So innovations, not just in terms of technology, but in terms of systems and processes. So I wanted to give 2-3 examples of the kind of innovative partnerships that we've had. So the first one which I wanted to go into, and this is, remember that UK is also a supporter and partner on the Pandemic Fund, the global funds, etc. And looking at partnerships with multilaterals in terms of promoting global health security, as well as now bringing in the climate and health. So on the example of innovative examples from the Caribbean, there was a partnership with the WHO and as well as the what is called WAHO, the Pacific organizations, American and Pacific, PAHO. So with that, there was a focus on looking at resilient health systems and the overall appraisal of the health systems from looking at safety, 3 pillars. So safety, resilience, as well as smart. So when, and this kind of tools which were developed looked at the determinants of health. So we are all aware that the importance of water, looking at energy, etc., are really important in terms of the outcomes. And doing this kind of climate health vulnerability assessments it helped around more than 400 health institutions in the Caribbean to look at these aspects and develop an action plan. And in the case of Caribbean, because they were small countries, it was also supported by the UK and by other organizations. So implemented this system, which has provided some interesting lessons. And now looking at a partnership with WHO on the Alliance for Transformative Action for Climate and Health, again looking at some of the tools which WHO has developed in partnership with countries and with other partners on the climate health vulnerability assessments, supported that in Pakistan and Indonesia in terms of implementing that. But now once the action plans are developed, it's the prioritization and implementation. And I think that's where we look at both maybe pilots being supported, but the domestic finance as well as looking at partnerships with the multilaterals becomes really critical in terms of the implementation. Because it's only a few prioritized actions, and we're hearing about some of these prioritized actions. The second which I wanted to mention, based on the lessons on work in Africa at the regional level on global health security issues, I think the political commitment to tackle these issues, working through the regional institutions, was really brought out. So the African Union supported the CDC, and the other development partners got around it to look at action plans in terms of supporting a One Health approach, capacity building, and the community actions and capacity building was really critical part of it. So partnerships with civil societies, piloting some of these approaches. And based on those lessons, we are also now partnering with ASEAN on a global health security partnership, but it is more demand-led because the already existing partners and the ASEAN Secretariat has a post-15 health action plan, and there are clear priorities which some of the other development partners are supporting. So we are bringing in two aspects. Obviously, it's demand-led, but also partnerships with civil society and research partners to look at a more bottoms-up approach, and also at the regional level. So I'll say at both the levels, because also working with the ASEAN Secretariat and strengthening the capacities as and where required for their public health emergency institutions, or developing a plan. And this is along with the partnership that we have with the Fleming Fund, looking at antimicrobial resistance, which is really critical. Because if you look at the sources of pathogens, these sources are really important if one has to look at One Health, which is environment, animal, and human health all together. And I'll end with the partnership with ADB, because that's really exciting in terms of we look forward to some of the innovations. So both the evidence as well as innovations in terms of making a stronger case for climate and health investments in the future, so that the larger investments can be taken forward. I'll end here. Thank you.
Thank you, Jaya. We'll come back to the rapid fire perhaps a little later. But moving to Luchika. Did you want to say something, Luchika? Me? Yeah, okay. Okay, I have learned a lot in the last 2 days, and I continue to learn from you and the team, Dr. Sahu and Shini here on TB. We've attended multiple sessions on it. So we're not going to ask you to explain what is the interlinkage of tuberculosis and climate. I hope all of you have attended many sessions, kind of understood that. But in this one, just focus on the practical tools. If you can share some community-led monitoring systems or some tried and tested TB innovations that can be adapted for broader pandemic preparedness.
Yeah, thank you very much. Thank you very much. Okay, good. And thank you all for being here. So, and also I really, as you said, I hope nobody wants explanations of the links of TB, not only with climate, but also, and unfortunately, and I want to thank Professor Reddy as well for mentioning, we still live with TB around us, and it's still such a burden. It's the biggest infectious disease killer. in the year 2025, we have tuberculosis that is the oldest, or one of the oldest that we know, still killing the most among the infectious diseases, right? And it's curable, it's preventable, it's treatable, it's cheap, and we know how to do it for so long, and we don't do a dent on it as much as we could, okay? We are getting there, but still we live with this shame to say so. But also TB is very much linked with animal health. You know very well the bovine TB, and there are parts of in Asia, but also a lot in Africa, that we have the Mycobacterium bovine that is leading a lot of cases. And also the very big link with the pandemic preparedness. We all lived through COVID, and the TB doctors and the pulmonologists were suddenly very loved. Usually we, the TB doctors, are somewhere in the back because TB is not very sexy, doesn't bring money, pharma is not all over us, we are not doing facial things, we are not doing dermatology, we are not cardiovascular. So usually when you deal with tuberculosis, is a booth near the toilet in a big conference, right? Suddenly the TB doctors became very famous, and they were on all television during COVID because they were dealing with lungs. They were the ones that knew how to wear a mask. In the year 2020, we had to do training about why it's important to wear a mask. And I'm happy we have here a friend of mine in the room, Tim Holtz, of CDC and now of George Washington University. He was a big part of all of us pushing when a lot of very prestigious organizations were doubting the airborne nature of COVID. Yes, WHO. We were the ones, true, very true. I have emails. Which I'm keeping for a book that I will write when I retire. We were, the TB doctors were the ones that were really knowing how to wear a mask and what the circuit of the airflow in a hospital and in a room is, and why it's important that the people that are sick don't meet the healthy ones on the corridors and so on. You know what I mean here. So it's the link, and that where when the TB hospital and the labs and the diagnostic tools were taken from TB to do COVID. And now COVID passed, and everything goes back to where it was. The TB doctors in the booth near the toilet, everything quiet, no more, so till the next thing comes. And God help if it's airborne, because TB is an airborne pandemic, okay? Now, you spoke about what tools we have. So because we were so beaten, and when you are poor and you deal with people that have a lot of vulnerabilities, you need to be inventive. And yesterday I said that we learn from pain and we learn from difficulties more than we learn from, when things are going very well. So we had to do in TB a lot of push and to embrace a lot of innovations. And there are a lot of tools that we have and that can be used and are used already to deal not only with TB. The time that we just do investments in just TB or just HIV or just COVID or just malaria passed. 27 of April 2025, forget about that, okay? That time passed. We need to invest in tools that help more than one disease. To be able in this era with so many struggles to get the funds, to get the right tools. So we have tools, and I will finish with the communities, we have tools for diagnosis doing that are helpful to diagnose not just TB, but several other diseases. Rapid molecular tests, the mobile X-ray, which is now so small, you can put in a backpack. We actually had a team that took it on Everest to prove that it can be carried, and very high, where they didn't have this tool, you do an X-ray with that, and AI is reading it, so you don't need to have a radiologist. You don't, things that when I did school were not possible, right? We have cough apps. We are looking now at a group that develops a swab for TB diagnosis. So things that are, and all of these are not doing just TB, maybe a bit less on the swab, even though I know that they are looking at multi-pathogens as well. But for example, with the X-ray one, once you do a test, you can find many other things that you have in your lungs and even on your spine and your ribs and so on. So it's a primary healthcare tool. It's a community level tool as well as the rapid molecular diagnosis. We all spoke, and I really, really appreciated the angle here on the communities and strengthening primary healthcare in communities. I cannot agree more. Yesterday in that panel, when I was asked, that's what I said. But I think, unfortunately, we are not doing it. I hope, Priya, that the funding you give, and we can have a chat over that, is helping with it. When COVID happened, we in Stop TB said, let's empower the communities, because they are the ones that are penetrating in their little community there. They know, and let's don't train them or have them ready for TB, but for anything, like a little army, ready there, equipped, willing to step in for whatever is happening. A flood, an earthquake, COVID, tuberculosis, HIV. They know the best, right? Or a primary healthcare unit. Now, we tried to do that. There are so many funding opportunities we know. Very little constructed that or contributed to that at scale. There are projects, successful ones, very little at scale to maintain and to make a difference. We have a tool which is called One Impact that you can put on your phone and is helping you to monitor and to trace the services and to explain how good, how bad they are, irrespective. We actually was very useful during the war in Ukraine for people to stay even in touch. So we have developed STB some of these tools that can be put in place. Important is to know and to want to do something. Because I think now in the year 2025 and in April, I think with the disruption in the funding, coming not just from the US funding being, being revised and readdressed and reshaped, but a lot of donors looking very seriously in their pockets because they need to buy guns to kill the people we save, okay? That's what's happening. But the investment in aid for health will become less and less. But now we realize that what we invested, we didn't construct too much on the health systems of the countries. We didn't construct too much resilience, because otherwise we would not have many countries being almost completely paralyzed, at least for some diseases, in their procurement and supply, in reaching their people with vulnerabilities, in ensuring access to diagnosis and so on, just by a 2 months interruption or disruption on the treatments. So I will end here by saying that there is a lot that we can learn from each other. As I said, from the TB side, we are very much looking at constructing a solid base that is serving not just TB, but the others. Whatever we do will for sure contribute to pandemic preparedness, will for sure contribute towards the climate, addressing climate-driven problems, but also contributes to UHC. People with TB are not the most comfortable people. They have a vulnerability. Very often they don't feel embraced to come and be reached with services. We will consider UHC the moment you have the people with TB all diagnosed and treated. I can speak like this for long, but I will stop here. Thank you.
All right. Thank you. Thank you, Luchika. We'll wait for the book. You're going to become a very rich woman. So.
Oh, God help some people in this world, yes. It will be a very interesting book with names and photos.
Yeah, here it's coming. You heard it for the first time on this panel. Yes. So, right, okay.
Yes.
Monica, the last question to you on the panel before we go to the audience. Your organization, Dakshin, is really at the vanguard of supporting or catalyzing, I must say, global South-to-South exchange with taking lessons from India, innovations from India, and expertise of India for the global South, and as well as learning from elsewhere. Can you share your insights on what we are discussing today here? Preparedness for the next emergencies or pandemic. How are you doing sharing this, the most cutting edge innovations that were developed in India during COVID, or in the other infectious diseases arena with other countries, and what are you learning from this experiment and the work that you are doing? Monica.
Thank you, Sumesh. And I'm really glad that you're spotlighting this shift of, global south, the shift which is happening, and it's there for everyone to see. So whenever anything happens, we start looking towards the global north for these high-tech technologies. So they are the saviors of the world.
They were.
They were, yes. But when it comes to the real world delivery, last mile equity, and adaptive governance, some of the most powerful innovations are emerging right here in the global south. From my experience in India and through South-South platforms like Dakshin, there are 3 things which I would like to highlight. In India, we have to do more with less. And that has led to very smart, scalable innovations, whether it is Arogya Setu during the COVID times, the Ayushman Bharat Digital Mission, or the low-cost newborn care units in the rural hospitals. These aren't just cost-effective. They are resilient. They are user-centric. And the lesson for the world here is, you always don't need expensive solutions. You need contextual designs, local ownership, and scale-ready systems. And what my other panelists have already insisted upon, the globe can actually learn from India about community-led systems. Even during the pandemic times, the Indian ASHA workers, they were the backbone of surveillance, contact tracing, and even vaccine outreach. So not only in India, but also in Ethiopia, Bangladesh, these community workers have delivered things, even at the most difficult times. So people who know me here, that I have been there as an implementer for these government schemes. And at the risk of digressing from the pandemic topic, I would like to share one small incident which happened with me. Long, long ago, when I was a nodal officer for maternal health in one of the states for Haryana. So in the urban areas, it was not the slum area, mind you. So it was the urban area, and one of the areas was having a lot of maternal deaths happening. And we had tried everything in the book. Everything means like everything. And I was discussing this, I happened to discuss this with one of my ASHA workers about a recent death, maternal death, which had happened in her area. And you know what she told me? She told me, ma'am, the ambulances arrive on time. Everything is in place. But the problem is, the streets are narrow. The streets are narrow for at least 2 kilometers. The ambulance, which was an ALS, it used to stand there 2 kilometers away from where the woman was having her labor pains. And by the time the woman would reach the ambulance and the ambulance would reach the hospital, there would be complications. Such a small insight. Such a small insight. and that actually changed everything. The only correction I did was an ambulance, a smaller ambulance, a BLS, stationed particularly for that area, so that ambulance could rightly, go at places and pick up the patient. And if I might say, the ASHA workers have acted as the living census in our country. They know each household, everyone in that household, who lives where, who comes there, who has died, who has delivered. They know everything about it.
Yeah, yeah.
And this was even useful during the COVID times. When we were trying to do all that contact tracing, they would know that X family has that Y person who was living in that area. He has recently come, and that he probably was the courier. So, the learning is that investing in these trust-based frontline systems is non-negotiable.
Yeah.
These systems, they respond faster, and speed is important in pandemics. These systems respond faster and build social capital, which no vertical program can replace.
Thanks, Monica, for the insights. We'll move to the audience. We have last 5 minutes, so if you can close it in a second, and just if you have anything else, close it, and we can move to the audience.
Sure. So my last point is the governance, which really worked well for India. The alignment between the state governments and the central government, that really acted well. So this intra-sectoral coordination kept the whole system functional during that time. So if I'm supposed to distill it whole, we offer the world lessons in innovations under constraint, in community trust as public health infrastructure, and in governance models that prioritize equity and speed. The future of global health isn't just about where the funds or vaccines come from. It's about who is solving these problems creatively, ethically, and at scale. And the Global South is leading that charge. Cool. We are no more fragmented voices. We are there at the negotiation block. Thank you.
Thank you, Monica. All right. After that very powerful remarks, those remarks from Monica, we'll go to the audience. We'll probably have time for 2 to 3 questions to any of our panelists. So,
Dr. Somesh, I've been told by Pallavi that we have about 15 minutes. So that's good.
Oh, we have extra. Yeah, that's cool. So we have time for...
Because we started late.
We started late. All right. Okay.
That's what I was trying to ask.
Always good to have bonuses. So, not that this is a year of bonus anymore. So, we'll go to the questions. We have Dr. Hemant from Nepal. I think if you can have a mic here.
Dr. Somesh, there's one person there who's asking a question.
Okay, just 1 second. So we have one question there. We have Dr. Hemant from here, and anybody else?
Yeah, I'm here.
1 second, sir. Any other question here?
So it's 1, 2.
Okay, we'll have 3. So, sir, you, Dr. Hemant, and then yourself, and then we'll go to the next one.
Yeah, and then we have Vanshika on the right.
Okay, cool. Sir, please go ahead.
Thank you so much. I'm Dr. Sam. I work for AIDS Healthcare Foundation. India Cares in India. We are a 47-country organization and working in the HIV space. My question is directly to the very first speaker on the pandemic, the INB, basically the International Negotiating Body, and the results that are coming out, or as the world knows, right now that the last round of discussions are going to happen. But then looking at I'm not the expert here on the treaty, or not have been part of any of the discussions, but as an activist, as a learner, one thing that we are noting is that there is no actionable legal provisions which are, or yet to be framed, or rather, that's missing out. The second part of my intervention is also about the section or the Article 12, which is looking at the pathogen sharing and those kind of issues which are very large, yet to be discussed, and then say that no negotiations, then no access, no details, then no treaty. That's what we are trying to learn. And after 3 years of waiting for this rollout to happen, and then the last round had to go ahead, I would request the learned, any of the speakers, or even the very first speaker, to kind of respond to that, please. Thank you so much.
Yeah, we'll get Nilesh to take that very quickly, Nilesh, and then we'll go to Dr. Himantu.
Thank you for that question. I wanted to see that AIDS person.
He's there.
I was looking here. Okay, very good question, and I fully agree on both components. The negotiations took 3 years. Ultimately, WHO serves as the secretariat to bring member states together, to provide a platform, to provide all the technical background about potential implications of the article. There are some provisions within the competence of WHO. There are some provisions beyond WHO's mandate. But in this environment of geopolitical tensions, and also with huge economic implications, both global West-South, this is what member states agreed upon. Some people might say that bad treaty is better than no treaty. But the devil lies in the details, and the pathogen access and benefit sharing mechanism, where the pharmaceutical companies are supposed to agree to give 20% of the new products of medicines, diagnostics and vaccines to WHO. And WHO is expected to distribute it according to the needs in an equitable manner. That article still stays. Out of those 20%, 10% is donation and 10% is at a very fair price. But the details of the arrangements, the mechanism, yet to be worked out by the conference of the parties, which is all the member states themselves, in the coming months. And that will be part of the pandemic treaty as an annex. But all of these need to be again agreed upon by the member states. We live in a very fragmented world, and I was so glad that the IHR amendments were agreed upon. There were also some dilution there. Similarly, INB, Intergovernmental Negotiating Body that worked on the pandemic treaty, they have come up with at least something. And then there is a lot of potential in the language. By the way, this is proposed to be agreed under Article 19 of the WHO Constitution, which is a legal mandatory requirement. If countries agree, then countries have to follow their constitutional process.
And then come back at it.
Yes.
Cool.
So there are huge potential for a very good pandemic agreement. Details yet to be materialized by the conference of the parties. But the first step is to agree on this even in the World Health Assembly next month.
Broad framework.
Thank you.
Sorry, we have to.
No, I just wanted to thank him.
Okay.
Thank
cool,
you.
cool.
But let's all pray and hope that the next pandemic will not be here until every negotiation is complete. Thank you.
All right. Luchika, you wanted to add something
Yeah,
very quickly on that one.
I want to say that, so thank you for all the work. I think prayers is what we need. Because to be honest, when the rubber hits the road, or more popular, when the shit hits the fan, congratulations and good luck with that. I doubt that most of these things will happen, okay? We learned it during COVID, so I'm a big fan of a country-to-country support. and for countries like India and others to step in, to take care of their people and take care around, because as you rightly said, if the pandemic comes while we do all this negotiation, and it has nothing to do with WHO, it's the member states, wordsmithing till 5 a.m. Huh? They were 30 hours negotiating words. And when the shit happens, they will be in the airport fighting over the masks, as we saw during COVID.
Right.
So enough with drinking water and thinking it's champagne. Let's say the things as they are.
All right. Thank you, Luchika, for those remarks. Dr. Hemant, our Ministry of Health leader from Nepal, quickly.
Thank you, Dr. Sumis, and thank you all the panelists for enlightening us in many ways. But please bear with my question, okay? Because we are talking about resilient system, we are talking about country-led system, we are talking about so many things. But when it comes in the implementation, and I'm specifically targeting pandemic funding. So you are coming with some prescriptions, you say. That means workforce, surveillance, and laboratory. But my requirement could be different in my country, you say, because I have done so much homework, but I have to choose among that, you say. So why, it's just a suggestion, why can't that be, left to the country, that you decide by yourself which areas you want to make your capacities, because I will give you an example. Like, we are the recipient of pandemic funding, you say, and I want to make health security plan of Nepal, but pandemic fund cannot support because WHO says they have naps. You see, this is one example I am putting. So please, anything you want to suggest us. Thank you very much.
You want to take that, Priya? Yeah.
Sure. No, thank you for that question. So I think there might be some disconnects and misunderstandings because we're very much country-led, country-driven. The way we articulate our calls for proposals, and by the way, they can change over time because we have several areas. But the way we articulate them, we make them as open as possible. So saying let the country say where are the gaps in its pandemic preparedness. So please, next time you submit a proposal, call us, talk to us. Don't be constrained. And perhaps one point while I have the mic, I very much agree with some of the points that Luchika made earlier, which is that I think one big innovation that we're making at the Pandemic Fund is that we're taking a disease-agnostic approach to pandemics. We don't know what the next disease X is going to be. Yeah. So we want you to make those investments that are not specific to one disease or the other disease. Make those investments in a way that you can use them for anything that happens next.
Thank you.
I'm sorry, while you look at that, I just want to say something here, and I'm happy you clarified. Yes, you'd never invite me again, I know. No, I want to say to the colleague from Nepal, you know the best, indeed, what's needed in the country. That's not just for Nepal, for everyone. It's a plea to all people from the country representing the governments. There is nobody in this world that you should allow to tell you what to do in your country. And if somebody comes, you should send them to take a walk. Okay? Thank you.
1 second, Pallavi. I think we have made one objective. We have achieved one thing by making that connection. So you want to go ahead?
I just want to say that Pandemic Fund does allow changes to be done to the objectives as well. We are doing it in one of our programs as well. Sometimes the IEs may not be aware of it, so you can set up a call with Pandemic Fund and sort this out.
I just don't want to continue this discussion.
Yeah. No, I think offline.
The fact what we have observed, I have put here.
Okay.
If you want to check, we can sit and we can discuss it further.
Yeah, that's
and
the
I
idea,
can give you all the details what is happening, all the details.
Let's do it. Let's talk.
Yeah.
One objective achieved. Cool. Check. We have a third question. Pallavi, I know you want to say something, but we have the third question first, and then. Okay. Sir, please, Mike. How much time? 2 minutes?
Yeah, we have 3 minutes.
3 minutes. So we'll probably have.
Sir, I am not a health expert, At the time of COVID, I was a senior citizen with mild depression and digestive health issue already being there.
Yes, sir.
And I did not use any vaccine or anything. I just used Ayurvedic medicines, diet, lifestyle, that's all, and no complications. I even didn't use any COVID vaccine. And I am still healthy. जो बाद में जो मेरा क्वेश्चन है, जो कोविड वैक्सीन के बाद जो अक्सर मीडिया में हमको सुनने में मिल रहा है कि ये कॉम्प्लिकेशन हो गई, ये हो गई, उसका क्या स्टेटस है, एग्जैक्ट स्टेटस क्या है?
So the question is, can we yeah, I think somebody should respond to that question in a second. Maybe, sir, if you can, I can request you. Nobody better to respond to than Dr. Reddy. He's asking about the
मैं समझ गया उनकी बात.
Yeah.
देखिए जो वैक्सीन्स बनाए गए उनमें वेरिएशन है और कॉम्प्लिकेशंस में भी वेरिएशन है. पता चला कि ये जो वायरस वेक्टर वैक्सीन्स है जिसमें एक वायरस का मदद से ये एंटीजन हमारे शरीर में प्रवेश करता है, उसका कॉम्प्लिकेशन था ब्लड क्लॉटिंग, वीनस क्लॉटिंग एंड आर्टेरियल क्लॉटिंग. और जो mRNA वैक्सीन्स का साइड इफेक्ट था मायोकार्डियल एंड पेरिकार्डियल इन्फ्लेमेशन, मतलब हार्ट मसल और पेरिकार्डियम उसका कवरिंग जो है उसमें इन्फ्लेमेशन. ये ज़रूर हुए हैं और इसका डॉक्यूमेंटेशन हुआ है, मगर ये देखना है कि किस मात्रा में हुए हैं और क्या जिनको वैक्सीन्स मिले हैं उनको फ़ायदा हुआ है या नहीं. अगर आप देखेंगे, again switching to English for everybody else, let me say that the people who received the vaccines had far fewer complications in terms of severe disease, hospitalization, intensive care admission, and death compared to the people who did not receive vaccines. It's not that the vaccines did not have some complications, but they were much less in numbers than the people who received the vaccines. Now, as far as the Ayurveda component of your question is concerned, certainly innate immunity is a very important component of any fight against infection. And people who have good healthy lifestyle practices like good diets, good physical activity, and meditation and relaxation and less stress are much more likely to combat any infection better than a person who has not been exercising all these healthy lifestyle habits.
Sir, we can do it offline. Sir, आप बात कर लेंगे एक बार. To close this session, I have one. Before we do that, I have one of my colleagues who has worked very hard to prepare this session. She had her hand raised, so I'll give her 10 seconds to say something. Pallavi, go for it. This mic is not working.
Thank you, sir. And it's an opportunity to ask this question. And it's not a question, just I wanted to ask something from Reddy, sir. So since morning, we have been hearing a lot on the primary healthcare, resilience, system, processes, community. And we all know that you are the expert, you who knows the primary healthcare, who knows the field, the community, and also the South-to-South collaboration. So if you have to give 3 wisdom to the entire team sitting here, what we should be doing, and 2 things what we should not be doing in terms of taking this discussion forward. Yeah, thank you.
A great closing, actually. So please, sir, nobody better to close.
I thought you have already run short of time.
Instretchable time.
Okay. See, as far as community connect is concerned, it's absolutely important that our primary healthcare systems are firstly responding to community needs. So firstly, identify what the specific prioritized needs are. Whatever may have been the planning done in Delhi or in the state capital, have that community needs assessment very clearly. The second thing is, make sure that your primary healthcare systems are adequately responsive. And when we are talking about primary healthcare systems, we are not only talking about public systems. We have public systems, we have private also providers, and we have voluntary agencies also providing. So I would say in that instance, we must take the help of everybody, all resources that are available, in order to configure a universal health coverage system in which all sections of care providers who are available are brought into play. The public system, the public sector must be more responsive, the private sector must be more responsible, and the voluntary sector must be more resourceful. If that happens, then we'll build a fairly good system. Okay.
Thank you, sir. Nothing better to close the session. So I would really like to take an opportunity to thank the panelists. May we have a round of applause for these esteemed panelists. And thank you to my co-moderator Rasta for doing this. So, and thank you for the audience on showing up on Sunday morning. So, thank you. Thank you.
Thank you so much. Let's take a photo.
Yeah, we'll take a photo.
Yes. Those photos they take,
I know.
Give it to me. Give it to
So
me.
let's give to someone. Srini, can you take also a photo? Yeah, no, they come.
Just model though. We can have a model.
Good afternoon. A warm welcome to all the panelists here. The topic for this session is medical education in India. I proudly call panelists who are present in this hall, and I welcome all the other members who are keen to listen to this session. Dr. Surya Narayan Raju, former member, MARB Board, National Medical Commission, New Delhi. So please. Is there? Yeah, they will come. Dr. J.L. Meena. Dr. Veer Bahadur Singh. Please. Please escort sir. Purva Prabha Patil. Please. Sanika. Sanika is the Vice President for External Affairs at Medical Student Association of India. Dr. Purva Prabha. I think we should start the session, sir. So with your due permission. So would you like to give the opening remarks for this session?
Good afternoon, everybody. It is very tough to speak in post-lunch session and to listen in post-lunch session. So please bear with us. Our two speakers, Dr. Meena is on the way. Probably he will come within 30 minutes or 20 minutes. And I don't know about the Surya Narayan. As you know, today's discussion in our session is medical education. What is medical education? What was status in the past medical education, and what is the present status in the medical education, and what will happen in the future also. So, status of the medical education in India, we will discuss in next 90 minutes. I hope you will bear with us. Thank you.
Thank you, sir. There was a session on human resource for health just an hour before. So when we talk about medical education, in terms of when we talk about three verticals of any university system, we talk about good education, we talk about good research, but I think that the next level is a translation of this good evidence to an action. I think the foundation is about a good education, which actually builds a foundation to have actual translation and which will help the community, the final beneficiaries. So in this context, Sanika, your thoughts as a Vice President, Medical Student Association of India, in terms of where there's a requirement of the education, the innovation that is needed, and what are the strengths and challenges?
Yes, thank you so much, sir. As a representative of undergraduate medical students in the country, I feel I'm very, very fortunate to be here and to make our voices heard. Maybe we are the biggest stakeholders in this entire ecosystem, but maybe we have the smallest voice. And thank you for making it heard here. So for when we we're talking about medical education, there is a long due change that is happening in the curriculum right now with the entire CBME curriculum and the foundation course underway. But there is a stark difference between the policies and the implementations at every college level. What we see, and usually the medical students are the ones that are caught in middle. And what we believe here is that medical education is not just imparted in medical colleges. Learning happens outside of it as well. And as a medical student, I feel peer interactions, learning with my friends, talking to my seniors, talking to my juniors and faculty has helped me equally than what a classroom learning and traditional methods have taught me. And that is also something that we believe here at MSAI.
Thank you, Sanika. Purprabha, would you like to use your, maybe you can read it. Did you share the slides in advance? No. I asked, but nobody told anything about sharing. Okay. You can start. They will be connected? Yeah. Then help.
Okay, good afternoon, everyone. I know this is a post-lunch session, and as Sir said, it's difficult to listen and to speak in this session. But thank you so much for making your way into this hall. By accident or intent, both are very welcome. Can I just have a show of hands? There's quite a bit of heterogeneity in the room, so just a show of hands. How many of you identify as medical students or residents? Wow, that's a big number. How many residents in particular? Yeah, that number goes down immediately. So when I was invited to speak on this panel, up until half an hour ago, I thought I would talk about brain drain and about the challenges of being a resident. And having sat through some other sessions on medical education and specifically looking at residents, I had a slight change of mind. So what I'm going to be talking about instead is what residency feels like. But before that, I'd introduce myself. Who am I? I'm an eye surgeon in training. I'm studying MS Ophthalmology at Kasturba Medical College, Manipal. Besides what I do in the hospital, I am a focal point for health at the UN Major Group for Children and Youth. I work as a research fellow with the WHO Collaborating Center for Emergency Critical and Operative Care. But, and what is of importance here is also, I know Sanika from the Medical Students Association of India, which I led about 4 or 5 years ago. But who am I really? I'm a tired and exhausted medical resident, mostly former artist and a mostly former skater. I do not have the time to do any of this anymore. And for those of you wondering what life looks like in residency, I just have a few pictures from a day in my life. And just the session before lunch talked about the joys and sorrows of this profession. So I'll start there. A usual day is full of seeing patients. On some days, we have about 200 to 300 patients standing outside the OPD waiting to be seen. There's OTs, a lot of it is paperwork, and I dedicated one slide to my laptop, which I carry around and attend public health meetings or try to do some of this work wherever I can, in duty rooms, in wards like those, etc. And the highs of my residency, despite it being truly exhausting to the core, there are weeks where I spend 72-hour shifts, despite being in a chill branch. Yet, there are things that I really derive joy from. Some of them being camps. This program has enabled me to go into the farthest corners of the state, to the most interior parts of the state, to find people from all sorts of backgrounds, socio-demographic, economic, physical, mental. And I have had interactions and conversations with so many patients that reinforce the importance of the work we do here, despite, again, it being really challenging and exhausting on some days. You know you get up for experiences like these, and these are experiences you're not going to get outside of this life. But that does come with lows. Most residents and medical students are in their early to late 20s, which is somehow something we forget. And as people in this profession, senior, junior, keeping the hierarchy aside, I think all of us think of residents as people that work in the hospital, but tend to forget that there is a life outside of it that does not necessarily pause. So the lows, I can keep talking about this on and on, but I don't want to make this a rant session, obviously. So I'm just going to touch upon things like not having the ability to take a leave if your parents are sick. I think the saddest people on earth are people who have doctors for kids. Because who do you choose? Your parents or somebody else's parents that you're taking care of. So that's just one of the things that is a constant conflict in my head. The exhaustion, the mental breakdowns, and sometimes also the question of who are we really doing this for and why. But I'm going to move past the sad bits, and I'm going to talk about, I have picked up from the medical education session pre-lunch quite a lot, and there was a conversation about support systems and joys. So I included a little bit of it in my presentation. What makes this whole process survivable? The privilege of having a support system. So I've put pictures of 5 of my co-PGs who are taking care of my patients and my consultations today for me to come here and have this conversation in the first place. Which is a privilege not everybody has. I am from KMC Manipal, which I'm sure at least some of you would have heard of and known. So I have the privilege of being in a place where I can ask for a leave for something like this. And it is not something that some of my other colleagues in other parts of the country are able to. So that's a very baby glimpse into what my life as a resident looks like. I know it's a little difficult to conceive when we're sitting here outside of the hospital, wearing fancy clothes, and having conversations that, to some extent, I'd go as far as saying are a little bit disconnected from the realities of our daily lives. Which is why I decided to start like this. Before jumping into what I think are things that need to be different. And I'm whole and solely building on a lot of conversations I've had since I landed in Delhi with people in positions that could actually make a difference. I think one thing that really disturbs me is the glorification of overworking. We had several conversations in several different rooms about how it is marvelous that doctors, that the volumes of patients that doctors see bring job satisfaction. And yeah, I do agree with that, but to what extent? And how much and how far are we going to glorify this without addressing the cost of this over-glorification that we have? Second is the need for honest conversations and raw feelings. I think most of us, when we join healthcare, I was an intern during COVID-19. I don't think at 23 I knew exactly how to handle more than 10 deaths a day. And this is something that nobody teaches you. You just learn to deal with grief, with substances, with toxic coping mechanisms, with all sorts of unhealthy coping styles, because we never have this conversation. And even mentioning that, oh, this emotionally affected me, is looked down upon in our profession. And the hierarchy makes it all the more different to have any honest conversation with anyone. And the recognition that not every resident has a supportive environment. I spent 2 slides talking about people that make it possible, make residency survivable rather. But this is not a reality for most people. And I come from a very privileged position when I say I have this support. This is something 95% people minimum lack. And I quote that statistic based on the conversations I've had with several residents across the country through different organizations that I work with. The 4th point on the slide is we did it too. And I think this is one of the most problematic things that we as a system breed. Every senior of yours will, if you're struggling, and I'm guilty of having done this on several occasions on my own as well. If you see somebody struggling, the first thought that comes to mind is, oh, that's sad, but it's okay, we went through it too. And until that doesn't stop, we are not going anywhere. All of these conversations we are having are very utopic, unless we truly sit down and address these mentalities that we carry as people, right from the grassroots to up top. And I don't mean to point fingers at a specific generation or an age group, but I think we do lack the realization that every generation that walks this earth is a little different than the ones that walked before. So the same structure, the same instructions, the same methods of working, the same techniques might not exactly fly with this one. We have seen the outcomes of a life of overworking and glorification of overworking in healthcare. Some of us have been recipients of the consequences of lives like those and aspire to not live the same ones in our future. And again, coming back to the acknowledgement that there are life events that cannot be paused. People pass away, families have troubles, there are financial crises, there are all sorts of crises, which I don't think we account for when we sit down and talk about residents as a part of the health workforce. And I'm going to quote Dr. and Professor B. Srinivas, the Deputy Director General of Medical Education and the Member Secretary of MCC, who spoke earlier today, again in the same session that I keep quoting. And he said something very profound. Joy is possible only after basic job satisfaction is met. Joy and happiness are the next levels to that basic satisfaction. So if the expectation is that medical students and residents should find happiness in their patients, there's only a point up to which they can, because your basic needs. There have been days when I've and my colleagues have not had the opportunity to go have a shower. You're running a fever, that's okay, take a paracetamol, sit it through. You have a medical appointment of your own, okay, maybe that can wait because you have a patient you gotta see. So when we talk about things like joy and happiness, I think you take away from people who go through these experiences and have ideas different from yours. So just a note to be a little mindful of the expectations of a resident is something that I wanted to really bring forward in this conversation. Now, again, this has been a whole, okay, this is this way, this is that way, but what could be done differently? And this is in no way an exhaustive list. This is not ideally how I would list out recommendations. But the things that come on the top of my mind when I hear a lot of these conversations in different rooms is dedicated leaves that you can actually take. There are leaves. The argument that I usually frequently get is, but you have 21 days of mandated leave. But who exactly is checking if it is even possible to access these? We as a country are yet to explore the option of locum shifts, which is something that's being done in other places, where you can call in doctors from a different hospital, from a different place of work, for just extra shifts when your regular staff is not able to cover it. Just for example, if I wanted to take a leave to come here, I have to offer a replacement, and that is only possible when you have a supporting cohort of people with you. If you lack that support, it is not possible to take the leaves that you're quote-unquote entitled to have. Brain drain, we keep talking about bonds. I can name at least 25 residents out of the batch of 250 in my own institution that would have opted for a separate specialty or that would have changed paths if they were allowed to leave. But the minute you get a PG seat, leaving comes at a huge price tag of having paid at least for your whole academic program, plus or minus the bond that comes with being enrolled in this program. So what we are essentially doing is we're systematically allowing residents and young doctors to be trapped in things that they thought they would enjoy, but they're now sure they no longer do. And the accessibility of postgraduate programs and medical education at large in this country is not a new subject. I know how much goes into the education that I'm gaining, which again, some might like to think of whether is truly justified, because when you talk about the service you do to your communities, I think we completely hide and disregard how much goes into it financially from our own families and from our own finances. So I think there's a big disconnect between these two conversations that running away from is not really helping us as a healthcare infrastructure. And dedicated time for theses. This is something that I was forced to put in here. Research is now mandated, and we talk so much about research output, and postgraduates should engage in research, medical students should engage in research. But do we truly realize these are people who barely have had the time to have a shower and a meal? So you are expecting stellar, top-notch quality research from these same people. And I keep saying this a lot. India has amongst the smartest minds in the world. And I will repeat that. There are so many successes we have as a healthcare system, but that is not what I'm here to talk about. I would really have liked to use this space to highlight what we don't have, so that is where we can go from. But in terms of policy structures, most of our policies are brilliant. The only problem is the implementation, whether they're monitored and evaluated, and especially when it comes to medical education, I think this is what we could do differently. We have guidelines, but who is following them? And who do you go to tell that these are not being followed, and what kind of response do you get? Again, as I said earlier, this is in no way an exhaustive list. This is just me trying to ignite a truthful, honest and raw conversation about what it feels like to be in this medical education system that we have spent so much time talking about. So I will leave with that, and I will thank you for sitting through this rant. And I hope that we are able to truly make something out of this space that we have here today before we go back and see how we can reform this medical education system as individuals and as a system itself. Thank you.
Respected dignitaries on the dais and off the dais, esteemed colleagues and friends. It is my pleasure to participate and bring some of the information from past, present, and also to give few suggestions for future of medical education in India. Medical education is very important in healthcare and is an essential service, and all of us are aware that it is a challenge to implement and extend to every citizen in a populated country like India. We have highly qualified and talented and excellent doctors in India, and also our doctors are popular, excellent, and recognized in almost every country in the world. Our doctors are serving in extremities like tertiary care and research institutions in the metropolitan cities and also in remote villages where the facilities are not readily available. I would like to bring it to your kind attention that the medical education in India, where such talented and experts are being trained, we have about 800 medical colleges and about 150 standalone PG institutions, training 120,000 MBBS and 80,000 postgraduates, including 15% super specialists. Every year, 2.5 million students are appearing for UG NEET and 250,000 students appear for PG NEET entrance tests. Over 30,000 students are still going abroad for training in foreign institutions and colleges. It shows that the medical profession is the most respected, and also they generate a lot of remuneration to their practices. We have one doctor for every 1,000 people, as against about 3 for 1,000 people in USA. Need to increase allopathic doctors from 1 to 2 is an objective in our country. I have mentioned to you that there is a great demand and also recognition for our doctors in all developed and every country in the world. We are discouraging students going abroad for medical education because their percentage of passes after coming back as a foreign medical graduates is very less and disappointing. It is only about 10 to 12% average. Of having so many doctors trained, are they unemployed? No, because ours is a populated country, still need a lot of doctors to distribute equally all over. Though there is a concentration in urban areas, now even the qualified specialists are moving towards the rural and district level. It is a great development, and also people are getting good care, health care in the community. Let me tell you why there is a great demand for doctors in India. The doctors in India are respected so high and they are treated next to God. Not only that, the good remuneration depends on the talent and also expertise. To maintain the good standards, we need to impose regulations, accreditations and recognitions of the institutions to maintain the good standards. Though the government monitor the systems, still the main responsibility falls on the institutions who extend the education and also the governments. The educations in India are mainly undergraduate and also postgraduate level. To create educational standards, once again there are two levels. One is at basic and standard level, and the second is the higher level of education where the training is given in institutions of national importance like All India institutions and other institutions. The regulations and standards have been maintained by National Medical Commission and also National Board of Examination and Government of India to meet and maintain the minimum standards. The National Medical Commission and National Board of Examinations have the following aims. Quality medical education is the priority, to train high-quality professionals, universal health care, and equitable distribution. That means, though to some extent the urban areas having more doctors and more qualified, slowly they are distributing and going towards the periphery. Medical research as part of their training and comprehensive training has been encouraged. What is comprehensive training? So far, the research is being contemplated mostly in allopathic and modern medicine. But the traditional medicine was neglected for a long time. Recently, after National Medical Commission, we have discussed and debated and given guidelines that traditional medicine specialties also to be given equal opportunity for the patient to choose and also the doctors to be given opportunity to avail the modern diagnostic services, molecular diagnosis, radiological diagnosis, in diagnosis, and also to study their medicines, how they are working to develop further, because so far they have been neglected. Another most important subject the Government of India has taken up is rating of the medical institutions to enhance the quality education and also health care. To bring the innovations in medical education at all levels by dynamic curriculum. What is dynamic curriculum? And it is always been modified, depends on the need, and also family adoption program to inculcate oneness of the training doctors to be attached with the family and study about the diseases and their habitats, study them in their entire course. To regulate and also to prevent unethical practices by unique ID for all professionals and link them to Aadhaar card. Maintain the medical registers and ethical standards of patient care. All these things are very important to make the standards and also to avoid unethical practices and to bring discipline amongst the practitioners. It is not enough. Why? Because the medical practices and knowledge is a continuous process, and with the scientific advances and research, we need to face a lot of challenges to bring all this advanced knowledge and the research outcome into curriculum, teach and train the doctors, upcoming doctors, and also to meet the local needs and to maintain international standards. It is a major challenge, even for the regulatory authorities, because this knowledge and research outcomes are continuous process. Whatever we studied few decades ago is totally changed now. Whatever we learned a decade ago, once again is changed. And all these advancements, research outcomes, investigators, and also that molecular and submolecular, all these things are happening very, very fast. With these, we have special challenges in medical education. The challenges are, in general, shortage of teaching faculty, all of you are aware. And if you continue the same pace of education and also training, probably it may take about 10 years to fulfill the present needs. That means always we will be lagging behind to train the faculty to fulfill the students' requirements. Inadequate clinical material. Government and private colleges have different problems, either infrastructure, teachers and students. In private sector, infrastructure will be adequate and will be up to date. Modern equipment is available. Whereas in government side, that infrastructure will be deficient, but good and meritorious students are available, and most of the times they try to cope up with the available infrastructure and continue to show the merit. Availability of teachers and specialists impact the training and also clinical outcomes. The specific challenges are cost of infrastructure. For undergraduates, to create an infrastructure, it will be costlier than the postgraduates. Different medical colleges have different capacity of intake and also training. Prescribed faculty and specialist teachers are not available because specialties are increasing and specialists are always be lagging behind. Especially in the private side, we see that the availability of clinical material, that is patients, are far less than the required for the number of students trained. There are patients, beds and hospitals in some government and other departmental hospitals, but most of them are not being utilized for training. The most important part I wanted to highlight is we need to give opportunity to the merit irrespective of their economic status. Unless we give special opportunity for them, the medical education may not grow further. That means we need to increase number of medical colleges in government sector, increase both undergraduate and postgraduate seats, utilize all clinical resources for teaching, promote all specialists as faculty, complex cycle to be changed by the regulatory authorities. Teachers from institutions of national importance shall be considered as teachers and their services to be utilized and mandatory requirement. If you do that and prioritize the PG medical education, probably this vicious cycle can be breakdown and we can complete and train the both undergraduate and specialist training at postgraduate level within 5 years. One of the suggestions is that all government hospitals should be considered as teaching hospitals. If you do that, probably the number of seats can be increased. And all postgraduate trainees should be considered as teachers again, especially when they are trained in central institutions. Every postgraduate trainee is a human resource and he himself can create a lot of jobs for others. Unutilized hospitals for clinical resource is by using all hospitals. Wherever there are specialists working, they should be redesignated as teachers by giving short-term training, give promotional options and push them towards training and also as a teacher. All hospitals of 200 beds and above shall be considered as PG training institutions either in government or in private. One of the most important point is raised by our chairman was make the PG as a priority, permit PG courses first, then add on UG courses later. By that, there are several advantages we find. Infrastructure and cost of upgradation will be less, improve the quality of patient care and potential for research activities. PGs contribute better to patient care and also closer to the community. That means when the rural hospital is attached to a medical college for training purpose, they have more clinical material to study and the same postgraduates will reorient the specialists or the whoever are the doctors working there to reorient and educate them. And the specialty care is available in remote hospitals. Other expected benefits are, one is the financial savings, increase human resource, contribute to better clinical care, and also start several allied specialties and technical, nursing and other trainees to help the patients better. We have started doing rating of institutions. Rating of institutions is very important for the institutions to bring up the standards, to create the competition among the institutions that itself will improve the standards and also training. Institutions have advantage of rating by getting recognition at national and international levels, further to attract good students and also patients to increase their revenues, to attract funding from various sources of national and international agencies. In summary, we are training about 2 lakhs doctors every year, and we find ever increasing demand of specialists, qualified doctors in the country and also outside. We should increase postgraduate seats immediately and add on undergraduate at a later date. Emphasize the quality in medical education with faculty development. Encourage comprehensive research, including and inclusive of traditional medicine and their practices. Thank you, one and all.
Thank you, sir. May I request, sir, you have a flight to catch, right, you said? You'll continue? Okay, please.
Good afternoon. Dignitaries on the dais, dignitaries of the dais, and dear friends. As you know, in this session, we will discuss about medical education, and I will discuss in next 15 to 20 minutes the medical education in India, what was the past, and what is the present, and what will be in the future. In the past, the first medical college was Calcutta Medical College, was established in January 1835. Then in February 1835, the Madras Medical College was established. In 1845, then Grant Medical College was established. After that, in 1946, there is a board committee was constituted by the government, and it recommends integrated health services, and there should be more medical colleges open in the country. After that, in the post-independence era, the government medical colleges increases, but the important issue is all medical colleges are urban-centric. The major transformation begins in last 15 years with a significant expansion in the number of medical institutions in government as well as in the private medical colleges. The government has launched the PMSSY, under which the 22 new AIMS institutions have been approved, and undergraduate courses have been commenced in the 19 of them. Simultaneously, the existing government medical colleges have been upgraded and many new ones established, particularly in the underserved states. How far we have come, and what are the key achievements? India has made a commendable stride in the field of the medical education over the decade. The key achievements includes increase in the number of institutions as well as increase in the number of PG and UG seats. India now has the largest number of the medical college in the world. The medical college increases from 387 to 731, MBBS seat from 51,000 to 1,12,000 seats, and PG is around 28,000 to 66,000 seats. Now you can see the medical colleges increases 89%, MBBS seats increases 118%, and the PG seats increases 133%. Then how is it possible? How it was possible? It was possible because of the standardization of the admissions. The introduction of the NEET brought the uniformity in the increase in the seats. In 2023, around 21 lakhs students appeared for the NEET UG, and the NEET PG streamed postgraduate admissions across the India. Then some regulatory reforms. done by the regulatory authorities. The National Medical Commission established in 1920 and replaced by NMC. The focus on the governance, faculty norms, transparency in the fees regulation. These two is most important part. Then, last but not least, the introduction of the next is a uniform licensure examination. Then, curriculum modernization, in which there is a from quantity to quality. We are producing the quantity of the medical students, we are producing the quantity of the postgraduate students, but we should be focused on the quality also. While the India produced the largest number of the doctors annually, concerned about their readiness to serve the effective as the growing. For this, how to improve the quality? The NMC has started competency-based medical education. It was launched in 19, revised in 23, and re-revised in 24. It focuses on attitude, ethics, communications, and early clinical exposure of the medical students. 80+ core competencies mandate for the undergraduate students in this CBME program. Some components of the new curriculum: the foundation course, the early clinical exposure. Initially, the clinical exposure was in second MBBS. Now, in the early clinical exposure, even the integrated education, the clinical exposure in the first MBBS also. Alignment and the integration, it may be in the horizontal and the vertical. ATCOM, this is an important, this is longitudinal, and the elective for the 1 month for the medical students. A specific skill development, this is an important part for the medical student to reform their career. The student doctor training, it is a longitudinal care. The formative assessment, previously it was not in our curriculum, it was mentioned, and the simulation-based learning or teaching is included in the teaching. The systemic feedback by the logbook or by the portfolio, remedial. Medical students and the medical doctors are very poor in the documentation, especially in the government sector. So it is important to document all the things, all happening in the paper. The SDL is a self-directed learning. Then next is government should keep in mind to invest in the public sector. Though the private sector is equally effective, but government should be keep in mind to invest in the public sector only. Then what are the current challenges and how and the way forward? The 75% of the medical colleges is still in the urban area. This is a challenge, but the 65% of population is still living in the rural area. So what is the solution? The solution is the rural service bond may be implemented, establishment of the rural medical colleges in place of government medical colleges in the urban areas, and incentive for the rural faculty. It was started and still it is in the Rajasthan, the two medical colleges, Badmer Medical College and Dungarpur Medical College, some incentive is given to the faculties who are posted at Badmer and Dungarpur. Then faculty shortage. This is again a challenge for the government as well as the medical commission. The 20% shortage in the faculty, especially in the new institution. I think this is in best of my knowledge, it's more than 50%. The faculty shortage are significant problem in the Indian medical colleges, which many institutions are struggling to meet the minimum faculty requirement at the time of inspection. This issue is particularly acute in the government medical college and in the newly establishment or in the upgraded medical colleges. So this is again is a major problem. Then why the faculty shortage? No one is interested to look into it. The government should look into it. NMC should be strict in this point. Rapid expansion of the medical college and the seats, lack of qualified faculty, policy changes. rapidly changes in the policy by government or by the NMC, lack of incentive and the support to the faculty members and the stakeholders, and ghost faculty is an important factor. The practice of the ghost faculty, where the individuals are listed in the faculty members but not actually teach attend the classes, important cause of it contributes to the problem. The attitude of the faculty, it should be changed. Then impact of the faculty shortage. What happens when the faculty will be short? The reduced quality of the education, definitely, strain of the existing faculty, impact on the student outcome, and challenge in the research and development. These are the 4 points. They have impact if the faculty is short. Then efforts to address the shortage. These are my suggestions. How we can improve the faculty shortage, increase faculty hiring. Government and the government authorities are working in the recruit more and more faculty members. Faculty sharing, but this is not, I think this is not allowed by NMC. They're relaxing the qualification norms. Again, there may be deterioration in the quality. Improving the infrastructure and salaries. Efforts are underway to improve the working conditions in the salaries of the faculty members, which can help. The focus on the quality or the quantity. This is again a question. So how address the faculty challenges? I have discussed. That infrastructure gaps. 30% of the private medical colleges fail to meet the NMC norms. Then what is the solution? The annual audits and the capital grants, especially for the medical college, government medical colleges. Skewed UG-PG ratio. 1.2 lakhs UG versus 66,000 PG seats. It creates a bottleneck. What is the solution? Either increase the PG seats or expand DNB seats, family medicine, community-based PG program or certificate courses. Then how we analyze the mismatch in the medical education? Population size, uneven distribution, high population density, rural-urban disparity, doctor concentration in the urban area. They want to go in the urban area only, not in the rural area, because the facilities are still not up to the mark in the rural area, and limited rural healthcare facility also. The postgraduate seats are decreased, low MBBS seat ratio, and the limited possibility of opportunity, and that's why there is a brain drain. Then, important part of the medical education is research. The weak medical research orientation of the medical institutions. India contributes only 2.8% of the global medical research publication, and we are having the maximum medical colleges in the world. In spite of that, our contribution is only 2.8%. Then what is the solution? Solution is start the research fellowships in undergraduate section and increase ICMR funding and mentorship program and other sources of the funding to increase their knowledge of this research. Then commercialization. This is again in India. Medical education is going to be commercialized. The capitation fees, this is source. I'm giving the source also. Capitation fees is more than dash dash dash. What is this? Transparent. How we can solve this problem? Transparent fees regulation, which is not all over India. All states, they have their own policy regarding the fees of the medical education. The centralized counseling for the admissions, especially in government as well as in the private medical college both. Then, siloed learning, the poor collaboration between the medical nursing and the public health education. Then solution, the integrated team-based learning modules and the joint clinical simulations. Then any project, if we are starting any project, there should be monitoring. Monitoring in the outcome monitoring is mandatory to see the project is working or not. No uniform tracking of the graduate performance, rural posting, or patient feedback in our medical education system. So the solution is to develop the national data dashboard for the medical education KPIs. Then measurable medical education outcomes. Maybe the short term, maybe intermediate terms, maybe the long terms. In the short terms, the improved student engagements, skill acquisition through simulation, formative assessment, and the feedback system. Then what about the intermediate outcomes? The better clinical decision making, improved patient interacting with the empathy, increase in the community-based learning. And in the long-term outcomes, quality of the healthcare services, reduction in the medical errors, better doctor-patient trust, improved healthcare indicators like IMR, MMR, and so on. Then, strategies for the improvement. The challenges and the strategy in the medical education, there are 4. Number 1 is the restructuring and the rural services incentives, then aligning with the WFME accreditation norms. Third is the embedding the community health in curriculum, and the last is the regulatory vigilance over the private colleges. In 2023, World Federation of Medical Education was visited in NMC for inspection. I was the coordinator of that team, and they have visited the MAMC, one government medical college, and one private medical college, that is some private medical college in the Delhi. And vigorously inspection for 2 days, and what was the result, I don't know, but their 5 members of the WMC was there. Then vision. Increase access without improving the quality, fostering research culture in the UG and PG, promoting community-based medical education, and introduction of the next. They have shortage of time, so I'll also short this. So to conclude, India's journey in the medical education reflects both scale and ambitions. With the over 700 colleges and 1.2 lakhs annual MBBS intake seats, it has been the largest medical education system in the world. However, challenges in the equity, quality and outcome remains. By that leveraging data, technology, policy reforms, and the people-first strategy, India can build a future-ready medical education system that ensure not just doctor, but competent, compassionate, and community-rooted healers. Thank you very much, especially for NIMS University, Dr. B.S. Tomar, and all organizing team for inviting me in this conference. Thank you very much.
Thank you so much, sir. I think the overall overview that you have given is very insightful. I now call upon Dr. Jael Meena to speak. Yes. Thank
you. Good afternoon to everybody. I think especially for the medical educations, the role of the National Medical Commission is the first, how we provide quality healthcare service to people of India. That is very important things. Before I say some things to the medical education, the quality is necessary. So as my knowledge, the very simple definition of the quality, जो आपको चाहिए वो दूसरों को दो, that means quality. If you are the patient, what is your expectation from the healthcare service? What this is the big question. Is we are true that जो आपको चाहिए, जो हमें चाहिए वो हम दूसरों को दे रहे हैं? That is a big question. Related to the quality, I always say the self-assessment is the best assessment for the improvement. मैं अगर एक सिंपल क्वेश्चन पूछूं कि आप में अपनी कमियां क्या हैं, वेरी लिमिटेड हो जाएंगी, लेकिन अगर पड़ोस वालों की कमियां पूछूंगी तो लिस्ट बहुत बड़ी हो जाएगी. But can we thinking the self-assessment? Can we thinking our strength? Can we thinking our weakness? Can we thinking our opportunity? Can we thinking our threats? If we focus on the self-assessment, we always in the top. The another important, we are always blaming to each other. If anything wrong, we are blaming. Sometimes, ये ऊपर वाला नहीं करता, नीचे वाला नहीं करता, बाजू वाला नहीं करता. लेकिन are you thinking what is your role? If you focus on your role only, you no need for other roles. Because you have 24 hours only. If you wastage the time to identify the weakness in others, it's a very difficult way. But if you give the time your weakness, then you will more powerful rather than the others. And it's always a teamwork. It's never achieved by a single person. So especially when we thinking for the medical education, here the number of the team is there. The National Medical Commission is the first team members. The Government of India is the second team members. The state government is the third team members. The private sector is the fourth team members. And the government medical college is also a team members. And especially the public which need the quality healthcare services, the another team members. Can we sit together for better quality healthcare services or blaming each other? When you prepare the National Medical Commission rule and regulations, are you do the field test that their rule are really applicable or not? They achievable or not? Are they provide the quality healthcare services to people of India? So this is more important. If you prepare any things, please do the field test also. Please see the reality. You cannot go directly to the top. You go step by step, because quality is not a continuous process. It's a continual process. First you achieve one step, then another step, and then third step. Recently I see the 780 medical colleges till today. The more than 1,18,000 UG seats, more than 55,000 PG seats. But in the population of India, they are very less. Some states have medical college within 1 lakh populations. But the major state, especially in the UP, Bihar, Jharkhand, they have the number of populations where the very less number of the medical college. Recently, each and everyone see that most of the populations not go to the only MBBS doctors. They are thinking for the specialist or super specialist services. But it's a very weakness for India that we have 1,18,000 MBBS seat and PG seat is only 55,000. That means more than 52% MBBS student, they are unable to do post-graduation because of the lack of the seat. This is the true reality. If any student achieve and pass out the NEET, is they are not intelligent? Can we thinking that all MBBS student go for the post-graduation? So this is very important. You increase the post-graduation first. You also increase the super post-graduation facilities. You also thinking for the rural. When we thinking, our previous speakers also tell for the rural and urban thinking. But the rural areas, the healthcare facility is very big issue, or especially in the faculty. But when you prepare the norms, can we thinking, especially for the non-clinical branches, can we thinking the online lectures? Because nowadays the number of the online classes is doing. Why we are thinking for always on the physicals availability? So we are also rethinking for the online classes. So the one of the best lectures give the lecture to the number of the medical college. And number of the student is benefited if a good lecture is there. So we are thinking according to the norms or according to the practical reality. Especially related to the medical education curriculum, we never thinking for the patient behavior, how behavior changes. For the quality healthcare services, I think so, when we see the curriculums, nobody tell. related to the quality and other things, financial management and other things. So this is also very important. Especially now, previous speaker already say that when MBBS doctors pass out, more than 1 crore rupees spent. Then you thinking, is he provide quality healthcare services? This is the really big question mark. If 1 crore rupees is spent only for the MBBS and after the post-graduations, you never think that he will provide the better quality healthcare services. So you regularize the fees structures also. How we regularize the fees structures? In government sectors, only most of the governments is thinking for the numbers. Why we are thinking for the numbers? Can we thinking our present institutes provide the quality healthcare services? So this is more important rather than thinking only the number. First, to realize that your present institute should be provide quality healthcare services. They should be in the infrastructure better, faculty better, and clinical materials. And especially in the private sectors, the infrastructure is good, but the clinical material is again a big question. Most of the private medical colleges are micro planning only for the date of assessment. This is the reality. Rather than they focus on the quality healthcare services. So our process of the assessment or approval of the medical college is also a big question. So my humble request to National Medical Commission and other things, that we are also thinking for the process of approval, for preparation of the National Medical Commission's rules, or for the practical reality of all the medical colleges. Because if we thinking that we achieve the goal for the quality healthcare services, we never achieve without team members. And team is all. It may be a National Medical Commission, Government of India, state government, private sectors, public sectors, or patient and our publics. So I cannot waste more times. This is the practical reality. But my last is only one, जो आपको चाहिए वो दूसरों को दो, that means quality. अगर ये realize होगा तो ही हम quality healthcare services को achieve कर पाएंगे. You know that one error can cause morbidity and mortality. और सबसे बड़ी दिक्कत यह है कि अगर एक गलती से कोई ऊपर पहुंच गया, हम उसे वापस नहीं बुला सकते. That is the big question for the health sector. That you focus on the quality. कहते हैं कि ऊपर वाला अगर क्वालिटी फोकस नहीं करता तो डीएनए बिटवीन द चिंपैंजी एंड ह्यूमन बीइंग्स 99.9 इज सेम, ओनली 1% डिफरेंस. So if the medical education cannot provide the quality healthcare service, we never achieve the quality healthcare service to the people of India. So first focus quality in the medical education. After that you realize the quality healthcare service to people in India. Thank you very much, and I thanks to team members all for invite as a speaker. Thank you very much.
Thank you so much, sir. I think truly it was a very reflective understanding of where we stand, what do we do next, and the emphasis of not just, as our theme is right now is scaling access, but also we need to ensure quality. And I think that emphasis was really great, sir. Thank you so much. I think it was a very interesting panel which we had in this particular session, wherein we have a particular stakeholders in front with the student associations over here who are a particular key stakeholder of this particular medical education, and the people who are setting the particular system, and who have a larger understanding of where we are coming from, what do we do, and where we are going towards. And I think this particular kind of a very diverse, heterogeneous panel which we had, I think it has come out to very interesting insights to what the medical education currently is, what has happened, and what could be the future. And I think currently I would like to request, just if you have any final remarks, like for just a 30-second or a 1-minute remark, that would be great. Your reflection, yeah, please, Sanika, please go ahead.
Thank you so much. After listening to the resident perspective after listening to the system perspective. I'm here, like, my closing remarks would be, what about the stage in the middle where we, like, I am pretty sure all the medical students here right now, undergraduate medical students here right now, are enrolled in some or the other coaching classes for their preparation for their NEET PG or any other entrance exam. And if our education is focused only on assessment and is focused only on exam giving, maybe that really is not the purpose of actual learning, and that fails the entire purpose of better healthcare, is what I feel. And so I would request the stakeholders here, and sir mentioned, like, when we do the decision making, all the team members should sit together and we should decide. But sir missed out on a very important stakeholder, Dr. Jalmina, that student, he didn't mention the team member as a student. So maybe we could get in our insight in this discussion and maybe have a better, like, because we are talking about our education, so maybe we can have our points also heard in this space. Thank you so much.
Most important part in a medical education is what happened over the last 100 years, what is going to happen in next 10 years is important. The knowledge and the outcome of the research is going very fast. The scientific advancements and the trials and the molecular, submolecular, genetic, radiological, and also the research which is beyond our imagination. The outcomes which should be compiled, introduced into a curriculum, and train them. Is it possible? That means whatever is the standard training for undergraduation should continue as a standard minimum requirements, and that should be continued. While continuing the basic education, the specialty training and research should be taken along with training of teachers, that means faculty development program. When it comes to the research, most of the times the research is not being given importance. Now we have taken a decision recently that and introduced dual degree program. First, this is a 5 years course. First 3 years will be postgraduate degree, and the next 2 years will be research program. They will be awarded postgraduate degree followed by PhD. If the good research is taken up, there will be a research funding also will be granted from ICMR to the tune of about 50 lakhs, and the PhD will be awarded at the end of that. This will be very attractive, and also introduction of good research where the research is neglected in most of the institutions and colleges. The future will be specialty training, teaching and training of the postgraduate teachers and research. These three are very important. Thank you.
Dr. Purva Prabha, can you just final remarks?
Thank you for giving me the floor, and it was enlightening to also hear about everything that has been happening on a macro scale when it comes to medical education. I know you said 30 seconds. I'm going to request for more than a minute. Thank you. There is a lot to say, but there are 2-3 points that I think I'd really do injustice to having come here if I don't touch. The first being, J.L. Meena sir mentioned the costs of medical education, and I think when we talk about things like a rural service bond, or why quality is not being delivered in care by this generation of doctors, I think it's also important to ask ourselves, as I also mentioned in my own intervention, how much did it cost? So if medical education in a country costs more than 1 crore, how do you expect doctors to go to the interiors of the same country and work for 50,000 a month? So I think those are reflections we really need to sit down and have and no longer can run away from as a system. The second being, from my own background of studying the rural and urban divide, my thesis for my MPH was titled The Inclination of Medical Students and Young Doctors Towards Rural Practice in India. So I think I'm well positioned to also talk about some of those findings in this session. And one of my key findings was that rural bonds do not work. My study was a systematic literature review, and it reviewed, in terms of total size of participants, there were more than 2,300 young medical students and doctors that were interviewed or answered questionnaires in the process of coming up with these findings. There was unanimous agreement in the fact that there is a need and there is a demand, even between doctors. They would love to go to rural areas and work for a few months, maybe for short contracts, if they're remunerated well, if they're able to move with their spouses and families, if they are given the choice of the posting, if they're given the choice to go to a place of their choice, which is closer to the communities they grew up with. So I think we'll only really arrive at solutions once we start looking at why problems exist, as opposed to slapping a compulsion on this is what you got to do as a postgraduate in this country. We are definitely taking a lot from the system in terms of learning how to deliver care, but I think it is a little unfair to not account for what the system takes out of you as a resident and as a doctor in delivering this care as well. I think there is again a lot to say, but I will just, in interest of time, end on saying there's only so far you can run with a fractured limb. And though we're making tremendous progress, I think we should also start, while we look at how far we walked, we should start looking at in what state and how can we turn this walk into a run. If we can truly look at the people delivering care in this system as individuals and humans as opposed to just a cohort of some young doctors and residents, I think that would change the way healthcare looks in this country. Thank you.
Thank you so much. Security, please.
How many medical students are there in this hall? Can you raise your hands? Quite a good number. Okay. How many medical teachers are sitting in this hall? Can I ask a question for medical students? Do you know what is CBME? Do you know or not? Raise your hands. Okay. Do you think this is beneficial or not? Yes or no? No one is agree. What about the teachers? Do you know, medical teachers know what is CBME? No, for the student perspective. We know that is beneficial, no doubt. That is beneficial, no doubt. But they don't know. It means the system is something, within the system there is something wrong. So, in my opinion, if any project we are going to implement and evaluate also. We are going to implement, there is no evaluation, so the result is the same. Thank you.
Thank you very much.
मैं आपको ज़्यादा कुछ नहीं कहना चाहूँगा। जब मैं मेडिकल कॉलेज में था, बड़े हवा में था। डॉक्टर्स की लाइफ का जो फर्स्ट एंड लास्ट हैप्पीनेस होता है, वो होता है मेडिकल में एंट्रेंस। उसके बाद में कभी लाइफ में इतनी खुशी नहीं आती। लेकिन व्हेन यू गो फॉर द रियलिटी, my first posting in one of the PSC and my first OPD in half of water. And when I am going to the sleep, all night I wait. Then I realize the quality healthcare services. Within 2 years, this PSC, one of the best PSC in India, and it's come in the Times of India. And it may be happen, at that time Honorable Prime Minister is a Honorable Chief Minister of Gujarat. I am the first, where the first district quality assurance officer is appointment within 3 years. In government sectors, its promotion is very delayed. But I am the first when appointed as a first district quality assurance officer. After that, the district is first. And within 5 years, I am the first from the first state quality assurance officer. And you know the Gujarat health sectors, from PSC to medical college, most of the healthcare facilities are accredited only for the quality healthcare services. And that's why I will say, if you focus on the quality, you focus on the patient safety also, you focus on the behavior of the student or behavior of the health staff also. And after that, I am coming in the National Medical Commissions. And during my tenures, the number of the medical colleges also increased. And we achieved world record, 3 world record. Highest medical college, highest PG seat, highest UG seats. But this time, we are also need number of PG seats is more. Number of the UG seat or MBBS seat is also more. Because the distribution between the PG, UG and medical college is very typical. One state where the one medical college within 1 lakh population, but another state is more than 40 lakh population, there will be no medical college. And especially when the MBBS student, because today, the present scenario, most of the pupils does not want to see to the MBBS student only. They want to see the specialist. They want to go for the super specialist. So we are focused on the each and every MBBS student should we go for the PGC. Without wastage of huge number of amount. If he spend number of the amount, you never expect for the quality when he reach in the field. So first you go for the root cause analysis. Accordingly, you prepare the National Medical Commission's rules also. And it's a teamwork. Rather than blaming game for each others, we sit together. We realize each and every person's problems. And then we solve accordingly, step by step. Then we 100% go for the quality healthcare services. Otherwise, if we blaming each others, it's very difficult to reach our goal. Thank you very much.
Thank you so much, sir. We do have one final remark from Dr. Anurag. I'll just give it to you.
Thank you very much. It was a very wonderful presentation. I'll just like take a 1 minute. Actually, I am one of the faculty in a medical college, and I'll have one question from Sanika and one from Ms. Patel. Ms. Patel, you are a postgraduate student, and nowadays district rural postings are there. So what you will say, it is good or bad?
My truest, independent, honest reflection, at least for me, my district rural posting, I got posted in District Hospital Udupi. And I think, so my background is I also worked as a CMO in my own hometown district. So I had some exposure to what I can expect, but speaking also on behalf of some of my colleagues, I think the kind of patients that you receive in a district hospital or in a government setup, I don't think you will encounter as a private
As
practitioner.
an ophthalmologist, you got a chance to work as an ophthalmologist in your DRP
I was
posting?
very privileged that
You
way.
got to operate cataract and all the
I
things?
have done 30 independent cases in my
DRP.
district hospital. in
That's a
district
good thing.
hospital
That's a
would
good
be.
thing.
But I know this is not the reality for most of the
Most of the
country.
PGs are going, and it's like a leave for them. It's a
Exactly.
duty leave for them because they are supposed to work as a MBBS there. So first of all, I like to thank all the panelists, and thanks to NMC for making all the regulations. One more question to Sanika. Sanika, are you agreed for exit exam? Because what I feel, whenever there is an exam for UG or PG, there are 2 internal examiners and 2 external examiners. And I also gone through the same stage, being a candidate for my exam. And the exam is a very stressful phase. So once you see your 2 internal examiners, you are little comfortable. They say, don't worry, externals will talk to them. Correct, Sanika? Now we are coming up with an exit exam. Then what is the use of having 2 external examiners to take up the final exams? Means the NMC don't have trust on the 2 external examiners. But we should not go as external examiners because there will be the next exit exam. Because 2 external are going, they don't have any interaction with the candidates. They don't know any candidates. They are having a fair assessment. So I think as an exit exam, is it necessary? First thing. Second thing, I learned a line that do a job which you love and you never have to work a day. Fortunately, my father is a doctor. My father did not wanted me to become a doctor, but I choose in doctor as my personal interest. I love to be a doctor. I proudly say I am a doctor. I have done my PG, and as Ms. Patil says, she is facing so many problems during the postgraduate things. You should love that, Ma'am Patil. I know there's a problem. I have worked for 72 hours continuously during my postgraduate days, but it's like, you will know and learn more. And I also appreciate Surya Narayan sir, who says that best doctors are found in India. And I think as sir said about the capitation fees, it's not the capitation fees, it's all in black and white now. There is no capitation fees. The tuition fees has increased to the level, and there is no word like capitation because NEET exam has come into existence. And I also went as examiner, as Veer Bahadur sir said, for the 2 colleges, Dungarpur and Barmed. I went as an examiner there. I asked most of the candidates, wherever I go, I ask my one favorite question, why you want to become doctors? So 99% students said, my Taudi said, my father said, my Buaji said, my uncle said. Menka, now you love or not? Because my pediatric subject comes in the final year. So by that time, they have started loving their course of doctor, but initially they have become doctor because of some or the other person who has said them. This is long to say, but organizers have given me just a minute. Best wishes to all of you and Sanika and Ms. Patil. Thank you very much. Thank you, organizers.
I'm just going to take 10 seconds because I want to respond to something about this. You talked about the love for your profession, and I wholeheartedly agree. You can't stay in something that you dislike. And I think I speak for a lot of us when I say we are in this because we love this, but at the same time, discounting the challenges and the struggles of the profession, I don't think is in the spirit of what we're doing here. And also, secondly, if we are wanting to run a healthcare system on the basis of love and altruism of the current youth population, I think we are building a really hollow system of healthcare there.
Thank you, Anurag sir. So we can move now, sir. So there is one more thing for Veer Bahadur sir. As sir said that Anurag sir has already addressed that idea also, but the thing is like the entrance examination is conducted by government. The counseling is also conducted by government. So I think there is no involvement of capitation, as sir is saying. So because the examination, the government is conducting examination and counseling is also being done by the government. So no, that's fine, sir. That's it's not official. It may be non-official, or the colleges those must be doing. But it is not the case otherwise. By the way, thank you so much, sir, for gracing this particular occasion. This is the last question, Anurag.
सर मैं मेडिकल स्टूडेंट तो नहीं हूँ। हेलो, हाँ, मेरा नाम है गिरीश अग्रवाल। मैं चार्टर्ड अकाउंटेंट हूँ और एज ए जनरल मैनेजर फाइनेंस BHL हरिद्वार से रिटायर हुआ हूँ। उससे पहले 10 साल कैपिटल मार्केट में भी रेगुलेटरी पोजीशन में काम किया है। बट आज की डेट में मैं हेल्थ और वेलनेस पे काम कर रहा हूँ और स्टार्टअप के रूप में आ रहा है, क्योंकि मेरे पर्सनल लाइफ एक्सपीरियंसेस हेल्थ क्राइसिस रहा मेरी लाइफ में बहुत ज़्यादा। करीब 25 साल मैंने डिप्रेशन झेला होगा और उससे रिलेटेड डाइजेस्टिव हेल्थ इश्यूज भी झेले, जो अल्टीमेटली मेरा आयुर्वेद, योग और मेडिटेशन से एड्रेस हो पाए। मेरा क्वेश्चन ये है कि क्या मेडिकल एजुकेशन इकोनॉमिकली वायबल है, जैसा कि मैडम ने भी कहा है और लोगों ने भी सवाल उठाया। अगर 1 करोड़ रुपए का इन्वेस्टमेंट है तो मिनिमम 15 लाख रुपए तो अपॉर्चुनिटी कॉस्ट उन फंड्स की हो गई जो गए आपके पास से, वो तो अलग हो गया। जबकि ज़्यादा पैसे नहीं मिलते हैं इनिशियली, जब आप सक्सेसफुल हो जाते हैं एज ए डॉक्टर तब भले ही आप कुछ भी कमा लें, बट जॉब में उतने ज़्यादा पैसे नहीं मिलते हैं। तो क्या ये इकोनॉमिकली वायबल है? और दूसरा है, मतलब मैं एज ए हीलर बनना चाहूँगा नेक्स्ट उसमें, इस साल तो उसमें तो जन्म में अपॉर्चुनिटी नहीं है, बट मैं एज ए हीलर बनना चाहूँगा।
प्लीज गो अहेड सर, प्लीज रिस्पॉन्स।
बेसिकली जो आपका जो क्वेश्चन है ना, आप इसकी वायबिलिटी की बात कर रहे हैं कि इतना पैसा इन्वेस्ट करके वो डॉक्टर बन रहा है, तो दिस इज नॉट द वायबिलिटी, दिस इज चॉइस, यू कैन से दे वांट टू बिकम ए डॉक्टर,
बट
दिस इज
सर
नॉट द
लाइफ में
वायबिलिटी।
फाइनेंस के बिना कुछ नहीं है ना सर। अगर आदमी उतने पैसे ना कमा रहा हो कि घर का खर्च चला पाए तो कैसे करेगा?
सर डॉक्टर बनने के लिए किसी बैंक ने तो उनको कहा नहीं है, अपनी मर्जी से लोग बनना चाहते हैं, पैसा है तो बनो, तो नहीं बनो। दूसरा मैं बता रहा हूँ, जो 1 करोड़ की जो बात आई ना, even in the सुनिए डॉक्टर साहब, डॉक्टर दीपक, even in the government college where the NRI seats are there, 1.15.
I know, sir.
You know?
Yes.
This is not only the private medical colleges, this is government medical college also. In the Rajasthan we are having the no in Ajmer.
और आप सीए हैं, आप किसी मेडिकल कॉलेज की बैलेंस शीट उठा के इवेल्युएट करिए हाउ मच दे आर स्पेंडिंग एंड हाउ मच दे आर गेटिंग, देन यू विल अंडरस्टैंड व्हाट आई मीन। इट शुड नॉट बी 1 करोड़, इट शुड बी 2 करोड़ और मोर देन दैट। और आपके जैसे, हमारे जैसे जो सो कॉल्ड नॉन अफोर्डेबल लोग हैं, उनके लिए सरकार ने 350 मेडिकल कॉलेजेस पूरे इंडिया में बना रखी है, जिसके अंदर करीब 50,000 सीटें हैं सर यूजी की, जिसमें वो एडमिशन ले सकते हैं। जैसा सर ने बताया, वो सेकंड ऑप्शन बाई चॉइस लोगों के लिए है। चलो, थैंक यू सो मच सर, थैंक यू सो मच फॉर कमिंग एंड
थैंक यू सो मच फॉर एवरीवन, जस्ट अ राउंड ऑफ अप्लॉज।
थैंक यू।
थैंक यू।